Now we are going to discuss the liver. So what is the normal weight of liver? Normal weight of liver is 1800 grams in males and 1400 grams in females. So it is 1800 grams in males and it is 1400 grams in females. You know that liver is having dual blood supply. So it is supplied by both portal vein and hepatic artery. How much blood supply is going from portal vein? Portal vein gives 75% of blood supply and hepatic artery gives 25%. Portal vein 75%, hepatic artery 25%. In a latest exam, there was one question that functional division or physiological division of liver into two halves is done by an imaginary line. And what is the name of that line? The name of that line is cholecystoscaval line, also known as cholecystovena caval line. So this cholecystovena caval line is an imaginary line and it passes from gallbladder fossa. Here you can see it passes from gallbladder fossa and it goes to the groove for IVC. Groove for IVC. Clear? So the functional division of liver into two halves is done by an imaginary line known as cholecystocaval line or cholecystovena caval line, which passes from gallbladder fossa to the groove for IVC. Second important point, who divided liver into 8 segments? So Conneaut divided liver into 8 segments on the basis of two structures, portal vein and hepatic vein. Conneaut divided liver into 8 segments on the basis of portal vein and hepatic vein, mainly on the branches of which structure? Portal vein. This is a frequently asked question. So these are the 8 segments. Here you can see what are the segments which are located in the right lobe. So here you can see segment 5, 6, 7, 8. These are located in the right lobe. So indirectly this question is asked in surgery that if I am going for right hemihepatectomy, what are the segments of liver which are removed? So it is 5, 6, 7, 8. Which are the segments located in the left lobe of liver? So it is 2, 3, 4. So indirectly, what are the segments of liver which are removed in left hemihepatectomy? So obviously it is 2, 3, 4. So in left hemihepatectomy, we are removing segment 2, 3, 4. In right hemihepatectomy, we are removing segment 5, 6, 7, 8. Segment 1 is known as caudate lobe. It is considered a separate lobe. Okay. Now see, in the right lobe, there are two sectors. If you see, this is the right anterior sector. So what are the segments located in right anterior sector? 5 and 8. And here you can see, this is right posterior sector. So what are the segments which are located in right posterior sector? 6 and 7. Similarly, in the left lobe, this is left anterior sector. What are the segments located in left anterior sector? 3 and 4. And this is the left posterior sector. In the left posterior sector, there is a single segment. And which segment? Segment 2. Clear? So right anterior sector contains 5 and 8. Right posterior sector contains 6 and 7. Left anterior sector contains 3 and 4. And left posterior sector is the only sector which contains a single segment, and that is segment 2. Now another important point, if you see the relation, this is the location of gallbladder. This is the location of gallbladder. So gallbladder is in close relation with which segments of liver? 4b and 5. So gallbladder is in close relation with segment 4b and 5. It means which segments of liver are involved at early stage in carcinoma gallbladder? 4b and 5. And which segments of liver are routinely removed in extended cholecystectomy performed for carcinoma gallbladder? 4b and 5. Simple. There is another term which is asked, that is trisegmentectomy. The other name of trisegmentectomy is extended hepatectomy. Clear? So if I am asking right trisegmentectomy, it means it is extended right hepatectomy. So what are the segments which are removed in right trisegmentectomy? So obviously you are going to remove the right lobe. Apart from right lobe, what? The adjacent segments or sector. So we remove segment 4A and 4B. Similarly, if I'm going to perform the left trisegmentectomy, that means it is extended left hepatectomy. So apart from removing this left lobe means 2, 3, 4A, 4B, I'm going to remove this adjacent sector, means which segment? 5 and 8. Now look at these two images. In the first one, I'm removing this much part of liver, means segment 5, 6, 7, 8, 4A, 4B. So obviously what is the name? This is right trisegmentectomy, also known as extended right hepatectomy. So this is right trisegmentectomy. Similarly, if you see this image here, I'm going to remove this much part of liver. So I'm removing segment 2, 3, 4A, 4B plus 5 and 8. So obviously this is extended left hepatectomy, also known as left trisegmentectomy. There are two one-liner questions which are asked. What is the name of segment 4 and what is the name of segment 1? So segment 4 is known as quadrate lobe. This is quadrate lobe. And what is the name of segment 1? This is caudate lobe. Segment 1 is caudate lobe. Lots of questions are asked about caudate lobe. First, what is the blood supply of caudate lobe? So it is supplied by both left and right branch of portal vein. It is supplied by both left and right branch of portal vein, mainly the left branch of portal vein. Now see the biliary drainage. If you see the biliary drainage goes to both left hepatic duct and right hepatic duct, but mainly it goes to left hepatic duct. And venous drainage of caudate lobe goes directly to inferior vena cava. Venous drainage of caudate lobe goes directly to inferior vena cava. It is not via hepatic vein. So what are the important questions related to caudate lobe? You must be knowing one condition, and that is known as Budd-Chiari syndrome. Clear? Budd-Chiari syndrome. So what happens in Budd-Chiari syndrome? There is hepatic venous outflow obstruction, mainly because of hepatic vein thrombosis. So whenever Budd-Chiari syndrome is because of hepatic vein thrombosis, whole liver is affected, but caudate lobe is spared. Why caudate lobe is spared? Because its venous drainage is going directly to IVC. So in Budd-Chiari syndrome, since caudate lobe venous drainage is going into IVC, caudate lobe is spared. And over a period of time, you will notice that what? Liver will be atrophied, but caudate lobe will be hypertrophied. So it is spared. If you see the rest of liver, that is atrophied over a long duration of time. But what happens? The caudate lobe is hypertrophied. It is hypertrophied. Simple. This is one property. If you see the second property, this is the liver, and here this is the bile duct. This is the gallbladder. Simple. This is left hepatic duct and this is right hepatic duct. You know what is the most common site of cholangiocarcinoma? It is hilum. So if malignancy is arising from the hilum, cholangiocarcinoma, and caudate lobe gives its biliary drainage to both right and left hepatic duct, obviously there is early involvement of caudate lobe. So in hilar cholangiocarcinoma, there is early involvement of caudate lobe. That's why we go for routine caudate lobectomy in hilar cholangiocarcinoma. So another important point, in hilar cholangiocarcinoma, we go for routine caudate lobectomy. Routine caudate lobectomy. These are the important points related to caudate lobe. Now see this diagram. It looks like Mickey Mouse. So whenever we are performing ultrasound, the portal triad looks like Mickey Mouse, and that's why this view is known as Mickey Mouse view. So what is this structure? Posteriorly, portal vein. On the right side or laterally, this is bile duct, and on the left side or medially, this is hepatic artery. So this is portal triad. Portal triad. On ultrasound, it is looking like Mickey Mouse. So what's the name of this view? This is known as Mickey Mouse view. Simple. So this is Mickey Mouse view. This is portal vein. This is bile duct. This is hepatic artery. Okay. Now see, there is one maneuver known as Pringle's maneuver. So in Pringle's maneuver, we pass one soft clamp in the foramen of Winslow, and we are going to clamp these three structures. So if I am going to clamp these three structures, which include portal vein as well as hepatic artery, so total blood supply to the liver is obstructed. So this is known as total inflow occlusion. So in this diagram, you can see here, I am going to clamp portal vein, I am going to clamp the hepatic artery. So what is the name of this condition? This is known as Pringle's maneuver. So it is also known as total inflow occlusion, in which we place soft clamp in foramen of Winslow, which is also known as epiploic foramen. So I'm going to compress portal vein and hepatic artery. So obviously bleeding is controlled from which structures? It controls bleeding from portal vein as well as hepatic artery. Bleeding is effectively controlled from portal vein because portal vein is a vein, there is lesser pressure. So here, bleeding is effectively controlled from portal vein, and since hepatic vein and IVC is not included in the portal triad, I'm not going to compress these structures. That's why bleeding is not controlled from IVC or hepatic vein. So another important point, bleeding is not controlled. Bleeding is not controlled from IVC or hepatic vein. So this is Pringle's maneuver, which is also known as total inflow occlusion. So here you can see this is pyogenic liver abscess, and this is the most common type of liver abscess worldwide. So pyogenic liver abscess is the most common type of liver abscess. Generally, it is seen in alcoholic males in 5th to 6th decade. It is pyogenic, so it is caused by bacteria. And what's the most common organism? Most common organism worldwide, it is E. coli. In Asian population or in India, it is Klebsiella. And in children suffering from chronic granulomatous disease, it is Staph aureus. So worldwide, it is E. coli. In Asian population or in India, it is Klebsiella. This is Klebsiella. And in children suffering from chronic granulomatous disease, this is Staph aureus. Staph aureus. Now, what is the most common route via which infection reaches the liver? So the most common route, it is bile duct or biliary tract followed by portal vein. So most common route, that is bile duct or biliary tract followed by portal vein. See, here there is collection of pus. If there is collection of pus, obviously what is the most common symptom? There is fever with chills and rigor. There is pain, there is tenderness, and in most of the liver disorders, there is anorexia and fatigue. You must be knowing that fatigue is the most characteristic symptoms. And another important point, since the most common route is bile duct and the most common cause is cholangitis. What is the most common cause of cholangitis? It is CBD stone. So if CBD stone is there or CBD obstruction is there leading to cholangitis, what is the most common LFT abnormality? So obviously there is raised ALP, and 20 to 25% patients will be having jaundice. So what's the most common symptom? The most common symptom is fever with chills and rigor. Another symptoms are abdominal pain, there is anorexia, fatigue, jaundice, it is seen in 20 to 25% patients, and most common LFT abnormality, that is raised ALP. Another important point, the diagnosis of pyogenic liver abscess is highly suggested by ultrasound or CT. It is highly suggested by ultrasound or CT, but the diagnosis is confirmed by aspiration and culture. So here, diagnosis, it is confirmed by aspiration and culture. Simple. And since pus is there, what we have to do, we have to drain. So in majority of cases, we are going to insert a pigtail catheter and we are going to attach it with a bag. So this is what kind of drainage? This is percutaneous catheter drainage, and we give antibiotics. So that's systemic antibiotics. So what is the treatment of choice? It is percutaneous catheter drainage plus systemic antibiotics. Right? How we follow up the patient, whether there is complete resolution of abscess cavity or still some kind of pus is left, so we go for ultrasound. So for follow up of liver abscess patient, what is the investigation of choice? It is ultrasound. Here you can see this is a case of amoebic liver abscess. An amoebic liver abscess is caused by Entamoeba histolytica. What is the route of infection? It is feco-oral. So route of infection, it is feco-oral. And what is the infective stage in amoebic liver abscess? So this is quadrinucleate cyst. It is quadrinucleate cyst. Simple. See, amoebic liver abscess is more common in developing countries because of poor sanitation barrier. So whenever this quadrinucleate cyst is ingested, it goes in GIT and there is a further division. So what happens? There is octanucleate cyst. It converts into octanucleate cyst. And after octanucleate cyst, how many trophozoites are released? 8 trophozoites are released. And these 8 trophozoites are going to cause, can you see here? This is ileum, this is cecum, this is appendix. So it is going to cause the formation of flask-shaped ulcers. Where? In the cecum. There is amoebic colitis where? In the cecum. And sometimes there is formation of a mass, inflammatory mass, that is known as amoeboma. And what is the most common site? Cecum and ascending colon. So the important question is, what is the most common location of flask-shaped ulcer, amoebic colitis and amoeboma in all these cases? Answer is cecum and ascending colon. Sometimes cecum and ascending colon both are given separate options as a separate option. So you will choose cecum. If both are given in one option, so you will choose cecum and ascending colon. After this formation of flask-shaped ulcers, what happens? Can you see this is portal vein? This is superior mesenteric artery. So these trophozoites are going to penetrate what? The capillaries, reaching to the superior mesenteric vein, then portal vein, and then these are reaching the liver. And these trophozoites are reaching liver. Name is Entamoeba histolytica. So it is going to cause histolysis of hepatocytes, necrosis of WBC. So because of histolysis of hepatocytes, necrosis of WBCs, what happens? In the liver, there is collection of reddish brown or chocolate brown material that appears like anchovy sauce. So it is also known as having anchovy sauce appearance. So in this patient, you can see here that this is the chocolate brown or reddish brown material being aspirated from the liver. And this is having what kind of appearance? Anchovy sauce appearance. This is anchovy sauce appearance in amoebic liver abscess. Okay. Now, in amoebic liver abscess, frank pus is not there. It is the necrosed WBCs and histolysis of hepatocytes. That's why here, most common symptom is abdominal pain. Fever is not the most common symptom. So what are the clinical features? Most common symptom, it is abdominal pain. There is fever. Just like any other liver disorder, there is anorexia and fatigue. And obstructive jaundice is rare. Obstructive jaundice is rare. There is histolysis of hepatocytes. That's why most common LFT abnormality, that is raised PT or raised prothrombin time. Here also, the diagnosis is highly suggested by ultrasound or CT, but diagnosis is confirmed by serology. So we go for amoebic serology by ELISA. Diagnosis, it is highly suggested by ultrasound or CT, but diagnosis is confirmed by, this is confirmed by serology, that is amoebic serology, and we go for ELISA. ELISA. What is the treatment? This is entamoeba histolytica, so obviously we give oral metronidazole. How much is the high dose? 750 mg TDS for 10 to 14 days. So what's the treatment? It's the high dose oral metronidazole. High dose oral metronidazole. And they ask you the dose also, 750 mg TDS for 10 to 14 days. For 10 to 14 days, and most of the patient become asymptomatic after 3 days. In majority of cases of amoebic liver abscess, since there is necrosed material, we are not going to aspirate. So questions are asked that what are the indications of aspiration in amoebic liver abscess? Imagine I'm starting high dose metronidazole, but there is no symptomatic improvement even after high dose metronidazole within 3 to 5 days. If patient is having high risk abscess where there is high risk of rupture, when the size of abscess is more than 5 centimeter, or patient is having left lobe abscess, if there is diagnostic uncertainty, we have to aspirate. Sometimes there is bacterial superinfection, means amoebic liver abscess is converted into pyogenic liver abscess, then also we have to aspirate. And high dose metronidazole is not safe in pregnancy, that's why pregnancy is also an indication. So these are the indication of aspiration. This is the treatment of the patient. But there are cyst passers or cyst carriers for whom we have to give intraluminal agents. So what are the intraluminal agents given for cyst passers or cyst carriers? The mnemonic is PID. P means paromomycin, I means iodoquinol, and D means diloxanide furoate. So these agents are given for asymptomatic cyst passers or cyst carriers. How to remember? Mnemonic is PID. What are the complications of amoebic liver abscess? So it can rupture into peritoneal cavity, it can rupture into pleural cavity, and it can rupture into pericardial cavity. Clear? So most common complication, the most common complication, it is rupture into peritoneal cavity, rupture into peritoneal cavity, followed by pleural cavity, followed by pericardial cavity. Pericardial cavity. Okay, in Bailey it's wrongly given that most common complication is rupture into pleural cavity. That's wrong. In Blumgart it is given peritoneal cavity. So this is the most common site of rupture. In this image you can see that there are multiple cysts in the liver, and these are what? Hydatid cyst. Here you can see the CT image also. So this is hydatid cyst, and this hydatid cyst is caused by Echinococcus. Which species? Most commonly by which species? Echinococcus granulosus. Echinococcus multilocularis is another species. This multilocularis is going to cause hydatid cyst in multiple organs, which looks like malignancy or metastasis. That's why there is a question that malignant hydatidosis is caused by which species? Multilocularis, because multiple organs are involved. So Echinococcus multilocularis, this is responsible for malignant hydatidosis. What is the definitive host for hydatid cyst? Definitive host is dog, and the intermediate host is sheep. What about man? Man is accidental dead end intermediate host without human to human transmission. There is no human to human transmission. Clear? So man is accidental dead end intermediate host without human to human transmission. Here also, what is the route of infection? The route of infection is fecal-oral. What is the infective stage? Infective stage is the eggs of Echinococcus. So the eggs of Echinococcus will be ingested. These eggs are converted into larva that is known as oncosphere or hexacanth. And this hexacanth larva is going to penetrate the duodenal capillaries, and after penetrating the duodenal capillaries, most of these larvas are going to enter into portal vein and then enters the liver. So the most common site of hydatid cyst is liver. Some larvas are going to bypass it, and certain larvas are going to enter where? Into IVC. So if it enters into IVC, it goes to right atrium, right ventricle, and then lungs. So second most common organ involved is lungs. So in hydatid cyst, the most common organ involved, that is liver, followed by lungs, followed by spleen, followed by kidney, followed by brain, followed by bone. Liver, lungs, spleen, kidney, brain, and bone. So most patients of hydatid cyst are symptomatic or asymptomatic. Most patients are asymptomatic, and there is asymptomatic palpable intra-abdominal mass because of multiple cysts in the liver. So what is the most common presentation? Patient is having asymptomatic palpable intra-abdominal mass, and that is because of hepatomegaly. So majority of patients are asymptomatic. Okay. And what is the most common complication? It's the intrabiliary rupture. Intrabiliary rupture. Okay. Here also, the disease is caused by a parasite. So diagnosis is highly suggested by ultrasound or CT, but the diagnosis is confirmed by serology. And what kind of serology? We go for hydatid serology by ELISA. So on ultrasound, you can see here that there is cyst within cyst appearance. Cyst within cyst appearance, and this is known as rosette appearance. Characteristic appearance, this is rosette appearance. Rosette appearance. And in hydatid cyst, there is ring-like calcification. Can you see here? So on CT, what kind of calcification? There is ring-like calcification. Ultrasound, cyst within cyst appearance, that is rosette appearance. On CT, there is ring-like calcification, but the diagnosis is confirmed by serology, and generally we perform what? ELISA. Serology, generally we perform ELISA. There is Cazzoni's test also, which is done, but it is obsolete. Why? Because it is having poor sensitivity and there is risk of anaphylaxis. So Cazzoni's test for diagnosis of hydatid cyst is obsolete. Now coming to the treatment, drug of choice for perioperative chemoprophylaxis, and that is albendazole. That is albendazole. And what's the alternative? It is the mebendazole. So the alternative is mebendazole. This is drug of choice for perioperative chemoprophylaxis. Now see the surgical interventions done for hydatid cyst. Most preferred for anatomically and surgically appropriate lesion is spare. This is most preferred for anatomically and surgically appropriate lesion. What is the full form? Puncture, aspiration of content, instillation of scolicidal agent, and reaspiration. Right? What is the scolicidal agent used? Most commonly used agent is hypertonic saline. And what's the percentage of saline? Here it's the 20%. Hypertonic saline, and the percentage is 20%. Another treatment option is cyst evacuation, in which we are going to evacuate the contents of the cyst, and after evacuating the content of the cyst, we are putting omentum and we are going to fix it. So what is the name of this intervention? This is cyst evacuation with omentoplasty or omentopexy. In this image, you can see that I'm going for excision of cyst around the pericyst. So this is known as pericystectomy. The third option is pericystectomy, and this pericystectomy is the most effective treatment for hydatid cyst. This is most effective treatment. So there are two important questions which are asked. Most preferred for anatomically and surgically appropriate lesions, that is PAIR, and most effective treatment, that is pericystectomy. We can perform hepatic resection also, but it is not commonly performed because it is most radical treatment. So hepatic resection is most radical treatment. There is another question which is asked, Gharbe's classification for hydatid cyst, and it is based on which investigation? It is based on ultrasound. So what is type 1, in which you can see that there is simple fluid collection. In type 2, you can see that there is floating membrane or undulating membrane which looks like water lily, and it is also known as water snake sign. This was asked many times in the form of image based question. So here you can see this is the ruptured scolex and it is floating on the surface. So this is floating membrane, undulating membrane, also known as water lily or water snake sign. In type 3, there are multiloculated or multiseptated cyst. It is having which kind of appearance? Honeycombing. So there is honeycombing in liver in type 3. But honeycomb liver, it is seen in actinomycosis. Honeycombing in liver, seen in hydatid cyst. But honeycomb liver, and this is seen in actinomycosis. Now see the type 4. In type 4, you can see there are solid areas also. There are cystic areas also. So this is complex heterogeneous mass. So type 4 is complex heterogeneous mass, and in type 5 there is calcification. We discussed what kind of calcification is seen. Ring-like calcification. So type 5 is calcified cyst. Now we are going to discuss the liver tumors. So what is the most common malignancy of liver? It is metastasis or secondaries. So most common malignancy of liver, that is metastasis or secondaries. What is the most common primary malignancy of liver? And that is HCC. Most common primary malignancy of liver in children. So this is hepatoblastoma, and most common benign tumor of liver, and that is hemangioma. This is hemangioma. This is focal nodular hyperplasia. Focal nodular hyperplasia is second most common benign tumor of liver. Second most common benign tumor of liver. What are the special features of focal nodular hyperplasia? If you see the tumor, this tumor is having central stellate scar. So on which investigation you can easily see this central stellate scar? On CT. So on CT, you can see that there is central stellate scar. Clear? And there is atypical vascularity. What kind of atypical vascularity? That there is a central feeding arteriole with multiple peripheral branches. So if you perform angiography, this is known as spoke wheel or cartwheel appearance. So on angiography, what kind of appearance? Here you can see this is known as spoke wheel or cartwheel appearance. Spoke wheel or cartwheel appearance. So there is central stellate scar on CT, spoke wheel or cartwheel appearance on angiography. Most of these patients are asymptomatic, diagnosed incidentally, and it's a benign tumor, so generally the treatment is observation. Whenever there is diagnostic uncertainty, in that case only we go for excision. So treatment is observation. In cases of diagnostic uncertainty, we go for excision. What are the important points related to hepatic adenoma? First, that it is having low risk of malignant transformation into HCC. Low risk of malignant transformation into HCC. Second, there is risk of rupture. And how much is the risk of rupture? It is 30 to 50%, very high. risk of rupture is 30 to 50%. Investigation of choice for diagnosis, we are going to diagnose it by CCT. Since there is risk of rupture, it can convert into HCC. So what is the treatment? For hepatic adenoma, we go for excision. So there is one similarity between hemangioma, focal nodular hyperplasia and hepatic adenoma. What? All these three are more common in females and all these three are associated with OCP use. Now we are going to discuss the hepatocellular carcinoma. See the risk factors first. So risk factors are broadly divided into three categories. Any factor which can cause cirrhosis is a risk factor. Metabolic disorders are going to increase the risk, and there are environmental factors which are going to increase the risk. So it's the hepatitis B virus, hepatitis C virus, alcohol, NAFLD, that is non-alcoholic fatty liver disease, primary biliary cirrhosis. So these are the important factors leading to cirrhosis which is going to increase the risk of HCC. The metabolic disorders which are going to increase the risk are hemochromatosis, excessive deposition of iron; Wilson's disease, excessive deposition of copper; glycogen storage disorders, especially type 1 and type 3; and alpha-1 antitrypsin deficiency. These are the metabolic disorders. The environmental factors which are going to increase the risk are cigarette smoking, anabolic steroids, fungal toxin, and what's that? Aflatoxin, and the radio contrast agent used, Thorotrast. Thorotrast is going to increase the risk of 4 situations: HCC, cholangiocarcinoma, angiosarcoma, and hepatic fibrosis. Hepatocellular carcinoma, it is the most common primary malignancy of liver. Worldwide, still, what is the most common cause? This is hepatitis B virus infection. Hepatitis B virus infection. Now see, because of vaccination or immunization, the hepatitis B virus induced HCC is decreasing because of vaccination or immunization. HCC is having one special property of vascular invasion, and because of this vascular invasion, in most of the patient at the time of presentation, the HCC is multicentric and bilobar. So there are multiple tumors in the liver involving both lobes. So this is multicentric and bilobar. So generally in how many cases? In 75 to 80% cases. Means in majority of cases at the time of presentation, the HCC is unresectable. Now coming to the clinical features. When multiple tumors are there in the liver, at the time of presentation, patient is having pain. So the most common symptom is abdominal pain followed by weight loss. So what is the most common symptom? This is abdominal pain followed by weight loss. Weight loss. Okay. What is the definition of significant weight loss? Whenever more than 5% weight loss occurs in 1 month, or more than 10% of weight loss occurs in 6 months, or more than 20% weight loss occurs in 1 year. That is significant weight loss. Clear? There is anorexia, fatigue, jaundice is seen in what percentage of patients? 10%. Tumor rupture occurs in 3 to 5% patients. The tumor is hypervascular. That's why whenever we put our stethoscope, there is audible bruit. You can hear audible bruit in how many patients? Approximately 25% patients. What are the tumor markers for HCC? You must be knowing alpha fetoprotein, and the second is PIVKA2. PIVKA2 is protein induced by vitamin K absence 2. So alpha fetoprotein, generally the value is more than 20 nanogram per ml, and this value is seen in 70% patients. It means alpha fetoprotein is not raised in 100% patients of HCC. It is raised in 70% patients, and what's the value? More than 20 nanogram per ml. And the second tumor marker is protein induced by vitamin K absence 2. What is the investigation of choice for diagnosis of HCC? It is triple phase CT. This is triple phase CT. And on triple phase CT, what is the diagnostic criteria? Here you can see there is arterial hypervascularization. This is arterial phase, and there is venous washout. This is venous phase. So there is arterial hypervascularization with venous washout. Another important question. In high-risk population, what is the investigation of choice for screening? So, investigation of choice for screening of high-risk population for HCC, and that is ultrasound. Investigation of choice for screening of high-risk population for HCC, that is ultrasound. Just like other malignancies, there is TNM staging in HCC also. But TNM staging is not adequate and not used commonly in HCC. So which staging is used in HCC? That is Okuda staging. And what are the components of Okuda? Remember how to remember? BATA. The mnemonic is BATA. So you can remember Okuda staging by the mnemonic BATA, full form bilirubin, albumin, tumor size, ascites. Okay. There is a treatment criteria. What's that? It is the BCLC criteria. For treatment of HCC, we use BCLC criteria, and the full form is Barcelona Clinic. This is Barcelona Clinic for liver cancer criteria. Barcelona Clinic for liver cancer criteria, and this BCLC criteria is based on which staging? Okuda. There are two kinds of presentations in HCC we discussed. We discussed that in 75 to 80% patient, this kind of presentation, multicentric and bilobar disease, 75 to 80%. And in 20 to 25% patient, what? Patient is having resectable tumor. So if there is multicentric and bilobar disease, obviously the tumor is unresectable. And if the tumor is unresectable, obviously we go for what? Palliation. We go for palliation. Whenever this tumor is resectable, there are two situations. One patient is having adequate hepatic reserve, because you know that one of the risk factors is cirrhosis, right? So if there is extensive cirrhosis, so if you go for the resection, what? There might not be adequate hepatic reserve. So first, if there is adequate hepatic reserve, and the second situation, if there is inadequate hepatic reserve. Adequate hepatic reserve is there, obviously we go for resection. And if there is inadequate hepatic reserve, we will go for transplantation. We will go for transplantation. Simple. So this is how we manage. Some patients are having advanced and metastatic disease. In HCC, there is hematogenous spread, there is vascular invasion. So most common site of metastasis is lungs. So in advanced and metastatic disease, we use one drug. Which drug? Sorafenib. Sorafenib, it is used in advanced and metastatic HCC. There are similar drugs which are used in malignancies and asked frequently. First, see imatinib. Imatinib is drug of choice for unresectable GIST. Unresectable GIST and CML. GIST is gastrointestinal stromal tumor. CML is chronic myeloid leukemia. And it is the first line drug used for unresectable and advanced and unresectable dermatofibrosarcoma protuberans. So three indications you have to remember. Drug of choice for unresectable GIST, drug of choice for CML, and the first line agent or drug used for advanced and unresectable DFSP, dermatofibrosarcoma protuberans. So this is imatinib. Similarly, there is sunitinib. Sunitinib is drug of choice for or second line agent for GIST. So this is drug of choice for imatinib resistant GIST. Imatinib resistant GIST. We use it in RCC also. So this is the first line agent for advanced and metastatic RCC. First line agent for advanced and metastatic RCC. And It is used in breast cancer also. What kind of breast cancer? Refractory and metastatic breast cancer. So used in refractory and metastatic breast cancer. Refractory and metastatic breast cancer. There is a new drug that is regorafenib. And you know, this regorafenib, it is third line agent for GIST. So this is third line agent for GIST. There is another drug, vandetanib. This is the only US FDA drug approved for advanced and progressive medullary thyroid cancer. This is only drug approved by US FDA for advanced and progressive medullary thyroid cancer. Advanced and progressive medullary thyroid cancer. There is another drug which is given in breast cancer, lapatinib. Lapatinib is second line agent for HER2 positive breast cancer. What is the first line agent? The first line agent is Herceptin or trastuzumab. So this is second line agent. Second line agent for HER2 positive breast cancer. HER2 positive breast cancer. Clear? And there was one question in All India long back about geftinib. Geftinib, it is used in carcinoma lung. What kind of? Adenocarcinoma lung in females who are non-smokers. So this is used in adenocarcinoma lung in females who are non-smokers. So this list is very, very important. Almost asked every year, you have to remember. There is a variant of HCC known as fibrolamellar variant. So this is having, fibro means fibrous stroma. It is having fibrous stroma and with embedded lamellar structures. Fibrous stroma, embedded lamellar structures. This tumor is having slow growth and it is seen in young patients. It is well circumscribed and non-encapsulated tumor. So it is seen in young patient. There is slow growth. This is well circumscribed, non-encapsulated tumor. Important point is, it is not associated with hepatitis B virus, hepatitis C virus infection and cirrhosis. It means in majority of patients, the condition of liver is good or bad? Good. So here, patient is young, tumor is resectable, condition of liver is good. That's why this tumor, it is having what kind of prognosis? Good prognosis as compared to HCC. Second important point here, alpha fetoprotein, it's normal. If alpha fetoprotein is normal, then what are the tumor markers which are raised? You have to remember, there is raised neurotensin and vitamin B12 binding globulin. Vitamin B12 binding globulin. So raised neurotensin, raised vitamin B12 globulin, and this tumor is resectable, seen in young patient, condition of liver is good. That's why it's having good prognosis as compared to HCC. Hepatoblastoma is the most common primary malignancy of liver in children. It is associated with familial adenomatous polyposis and Beckwith-Wiedemann syndrome. You know that low birth weight increases the risk of hepatoblastoma, and alpha fetoprotein, it is raised. In hepatoblastoma, alpha fetoprotein is raised. And very important point, hepatoblastoma is not associated with hepatitis B virus infection, hepatitis C virus infection, cirrhosis or metabolic disorders. It means in this patient also the condition of liver is good. Here, the tumor is having hematogenous spread, and because of that, what is the most common site of metastasis? the most common site of metastasis is lungs. See the clinical features. Most patients are less than 18 months of age, most patients, and all patients are less than 3 years of age. Right? What is the presentation? So when the mother is giving bath to the baby or changing the clothes, mother is going to notice what? Abdominal lump, which is asymptomatic. So the most common presentation, what is the most common presentation? First, it is asymptomatic, palpable, intra-abdominal mass. And what is that? Mass is the liver, so hepatomegaly. So it is asymptomatic, palpable, intra-abdominal mass, and that is hepatomegaly. What is the most common laboratory abnormality? These patients are having very high platelet count. So there is thrombocytosis, and we discussed what is the most common site of metastasis. It is lungs. Investigation of choice for diagnosis is biopsy. For confirmation, we need biopsy, but radiological investigation of choice is CCT. So if it is radiological investigation of choice, answer is CCT, but investigation of choice for diagnosis is biopsy. In majority of cases, tumor is resectable, condition of liver is good. So what's the treatment? Treatment is resection. Treatment is resection. Now imagine a situation that patient is having metastasis at the time of presentation. So we give chemotherapy to downstage the tumor and then we go for resection. So in cases of metastasis or in cases of advanced disease, we go for neoadjuvant chemotherapy followed by surgical resection. So this is all about liver. Now we are going to discuss the spleen. So what are the indications of splenectomy? The most common indication of splenectomy, and that is trauma. It is trauma. And most common indication of elective splenectomy, and that is ITP. ITP, what is the full form of ITP? It is idiopathic or immune thrombocytopenic purpura. So here what is the problem? There is formation of autoantibodies against the platelet. So antibody coated platelets are destroyed in the spleen, and because of that what happens? This is idiopathic thrombocytopenic purpura. So patients are going to develop thrombocytopenia. Simple. And because of this thrombocytopenia, there is epistaxis, there is gum bleeding. One important point you have to remember, typically in patients of ITP, the size of spleen is normal. So important point, in ITP, the size of spleen, it's normal. That's normal. There is formation of autoantibodies. So what are the drugs we give in the management of ITP? Steroids, we give azathioprine, we give cyclophosphomides. So what are the drugs used in the treatment? We give steroids, we give azathioprine, and we give cyclophosphamide. Okay. Important point which you remember for exam, that is size of spleen is typically normal. It means in this case we can perform the splenectomy. What kind of splenectomy? Laparoscopic splenectomy. So what is the gold standard treatment for ITP? And the gold standard treatment for ITP is laparoscopic splenectomy. That's the laparoscopic splenectomy. Now see the important one-liner questions which are frequently asked. What should be the minimum platelet count for elective surgery? So if we are taking any patient for elective surgery, the minimum platelet count should be 1 lakh per mm cube. And if we are taking a patient of ITP for elective surgery, the minimum platelet count should be 50,000 per mm cube. This is frequently asked question. Minimum platelet count for elective surgery 1 lakh per mm cube, and for elective surgery in patients of ITP it should be 50,000 per mm cube. It means in patients of ITP during surgery, we have to go for platelet transfusion. So what is the best time for platelet transfusion in the patients of ITP? After ligation of splenic artery, so that whatever platelet you are giving, it should not reach the spleen. So best time is after ligation of splenic artery. It's the after ligation of splenic artery. Okay, now see what are the complications of splenectomy. So see the diagram first. This is the dome of diaphragm, this is the stomach, this is the duodenum, this is the pancreas, and here is the spleen. So whenever you perform splenectomy, there are lung related complications. So what's the most common complication overall which is lung related? There is atelectasis. So overall most common complication is atelectasis. It can lead to reactive pleural effusion, or it can cause consolidation or pneumonia. Consolidation or pneumonia. So overall most common complication is atelectasis. What is the complication which is diaphragm related? Here there is collection of pus. So that is subdiaphragmatic abscess. It can lead to subdiaphragmatic abscess. What are the complications related to pancreas? Since in the hilum there is tail, so there can be injury to tail of pancreas. Injury to tail of pancreas. There can be acute pancreatitis. So it can lead to acute pancreatitis, and it can lead to pancreatic fistula. Pancreatic fistula. What are the thromboembolic complications? So there is stasis, which is going to increase the risk of DVT, and because of deep venous thrombosis, what happens? There is increased risk of pulmonary embolism. There is increased risk of pulmonary embolism, right? So these are the complications seen in post-operative period. There is one complication which is most common, late and fatal complication, and this is what? OPSI. So what is OPSI? OPSI is overwhelming post-splenectomy infection. And see, this is most common late and fatal complication of splenectomy. So late means it is generally seen after 2 to 5 years of splenectomy. Seen after 2 to 5 years of splenectomy. And how much is the mortality rate? The mortality rate is 40 to 50%. So this is most common late and fatal complication. See, the least risk of OPSI is seen in trauma patients, and the maximum risk of OPSI is seen in hematological disorders. So there is least risk of OPSI in trauma patients, and there is maximum risk in hematological disorders. Maximum risk in hematological disorders. Okay, what is the problem? You know that spleen helps in the phagocytosis of capsulated organisms. So after splenectomy, there is increase in the infection by the capsulated organisms, and 3 organisms which are most important: Strep pneumoniae or Pneumococcus, Neisseria meningitidis or Meningococcus, and Haemophilus influenza type B. So out of these 3 organisms, which organism is most commonly responsible for OPSI? It is Strep pneumoniae or Pneumococcus. Other organisms are Neisseria meningitidis or Meningococcus and Haemophilus influenza type B. So it is easy to prevent OPSI, but it is difficult to treat OPSI. So how we are going to prevent OPSI? By vaccination. So how to prevent OPSI? By vaccination. What is the best time to give vaccine? At least 2 weeks before elective surgery and as early as possible after emergency splenectomy. So best time to give vaccination? At least 2 weeks before elective splenectomy and as early as possible or as soon as possible after emergency splenectomy. Emergency splenectomy, this is also a frequently asked question. So best time to give vaccine, 2 weeks before elective splenectomy, as soon as possible after emergency splenectomy. Now see the questions related to splenic cyst. What is the most common true splenic cyst? It is most common true splenic cyst, and this is hydatid cyst. This is hydatid cyst. How much is the incidence of hydatid cyst? That is 10%. What is the most common non-parasitic cyst? And this is pseudocyst. Pseudocyst means after trauma there is hematoma in the spleen which is lined by granulation tissue. There is no epithelial lining. Pseudocyst. And how much is the incidence? 70 to 80%. And most common congenital splenic cyst is epidermoid cyst. That is epidermoid cyst. So if a question is asked that overall most common type of splenic cyst, so if you see overall most common type is pseudocyst. But since it is a false cyst, the most common true splenic cyst is hydatid cyst. Now see the important questions related to splenic tumors. What is the most common tumor of spleen? And that is non-Hodgkin's lymphoma. It is lymphoma. Which type? Non-Hodgkin's lymphoma. What is the most common primary benign tumor of spleen? You know that spleen is considered as blood bank of the body. So most common primary benign tumor of spleen, and that is hemangioma. And you can make this hemangioma malignant. So what is the most common primary malignant tumor of spleen? So this is angiosarcoma. It is angiosarcoma. Now see the question. Most common primary for metastasis to spleen, and this is malignant melanoma. But in malignant melanoma simultaneously 2 to 3 organs are affected. Means in metastasis 2 to 3 organs are involved. So most common primary for metastasis to spleen, and that is malignant melanoma. Right? But if question is asked that what is the most common primary for isolated secondaries to spleen, it means metastasis is only in the spleen, and that is carcinoma ovary. Carcinoma ovary. So these are important points related to spleen. Now we are going to start portal hypertension. So how much is the normal portal pressure? Normal portal pressure is 5 to 10 mmHg or 10 to 15 centimeters saline. So how much is the normal portal pressure? Normally it is 5 to 10 mmHg or 10 to 15 centimeters saline. So what is the definition of portal hypertension? Whenever the portal pressure is more than 10 mmHg. This is the definition. There are two universal manifestations of portal hypertension. One is esophageal varices and the second is splenomegaly. So what are the universal manifestations of portal hypertension? Esophageal varices and splenomegaly. It will be seen in all patients irrespective of etiology. Okay. So another important point, at what pressure esophageal variceal formation begins? So esophageal variceal formation begins whenever the pressure is more than 10 mmHg. And esophageal variceal bleeding occurs at what pressure? Variceal bleeding occurs whenever the pressure is more than 12 mmHg. So variceal formation whenever the pressure is more than 10 mmHg. Variceal bleeding whenever the pressure is more than 12 mmHg. Now see, what is the etiology of portal hypertension? The worldwide most common cause of portal hypertension, it is cirrhosis. And what is the most common cause of portal hypertension in children? This is extrahepatic portal venous obstruction. In short, we call it as EHPVO. Extrahepatic portal venous obstruction. Now see the question, what is the most common cause of pre-sinusoidal intrahepatic portal hypertension? This was asked many times. Pre-sinusoidal intrahepatic portal hypertension, and this is schistosomiasis. Schistosomiasis. Now coming to the cause of death. Most common cause of death in cirrhosis, it is hepatic failure followed by variceal bleeding. So this is hepatic failure followed by variceal bleeding. Variceal bleeding. And sometimes it has been seen that variceal bleeding is going to precipitate the hepatic failure. So the most common cause of death, that's hepatic failure followed by variceal bleeding. Now what happens in patients of portal hypertension? Whenever the portal pressure is raised, generally the cause is obstruction, or because of increased resistance there is increased pressure. So what happens in portal hypertension? There is formation of venous collaterals at the sites of portosystemic anastomosis. So what are those important sites of portosystemic anastomosis? First, see, this is the GE junction or lower third of esophagus. Here you can see this is the left gastric vein, a tributary of portal vein, and here this is azygous vein, which is a tributary of systemic vein. So there is portosystemic anastomotic site between these two structures, and because of formation of venous collaterals there is formation of esophageal varices. So here you can see esophageal varices. Similarly, in the rectum, here you can see there is superior rectal vein, which is a tributary of portal vein, because superior rectal vein ultimately drains into inferior mesenteric vein, which goes to splenic vein and finally into portal vein. And here you can see there is inferior rectal vein and there is middle rectal vein. So it forms portosystemic anastomosis near rectum, lower third of rectum. So what happens? There is formation of rectal varices. Formation of rectal varices, which can lead to bleeding. Third, this is umbilicus, and here you can see this is paraumbilical vein, obviously a tributary of portal system, and there are superior epigastric and inferior epigastric veins. So here there is formation of venous collaterals, and what is the name? It is caput medusae. So how caput medusae looks like? So here you can see this is the umbilicus. Around the umbilicus you can find what? The dilated venous collaterals. This is caput medusae, and if you are going to put your stethoscope over caput medusae, you are going to hear venous hum, and this audible venous hum is known as Creuel-Hayer. This is known as Creuel-Hayer Baumgarten murmur. Creuel-Hayer Baumgarten murmur. One important point. Second point, that there is formation of esophageal varices, and in majority of cases the bleeding occurs from which part of esophagus? From the lower 3 cm of esophagus. So if this is esophagus, in esophageal varices bleeding mainly occurs from lower 3 cm of esophagus. How it looks like? So here you can see the appearance of esophageal varices on the endoscopy, right? So it leads to bleeding. So see here, this is esophagus, this is the stomach, and blood goes into stomach. It collects into stomach, and on that blood there is action of acid. So what is the color? The color becomes coffee colored, and after that patients start hematemesis. There are episodes of hematemesis. So because of hematemesis, what happens? There is loss of blood. So whenever these patients are brought to your emergency, what is the first step after airway, breathing and circulation? Put 2 large bore IV cannula, start IV fluids, and what is the fluid of choice? Ringer lactate. So what is the fluid of choice? The fluid of choice is Ringer lactate. Simple. What should be the cutoff systolic blood pressure? Cutoff systolic blood pressure should be 100 mmHg, and cutoff hemoglobin should be 8 gram%. So cutoff systolic blood pressure, that should be 100 mmHg, and cutoff hemoglobin, that should be 8 gram%. So what is an indication of blood transfusion in the patient of variceal bleeding? Whenever the hemoglobin is less than 8 gram%. After that we have to control the bleeding. Means we have to start the drugs. Pharmacotherapy. So what is the drug of choice for controlling bleeding? Drug of choice for controlling bleeding is octreotide. This is octreotide. Alternative is terlipressin plus nitrates. Octreotide followed by terlipressin plus nitrates. Clear? Bleeding is controlled. After that, there is collected blood inside the stomach. So what we have to do? We have to perform the gastric lavage. And gastric lavage should be done with room temperature saline to prevent hypothermia. So we have to perform gastric lavage. And this gastric lavage is done with room temperature saline. You should not use cold saline. Why? Because cold saline can lead to hypothermia, and hypothermia can cause coagulopathy. Now the stomach is clear. One simple question which was asked many times: first investigation done in any patients of upper GI bleed. So in any patient of upper GI bleed, the first investigation done is endoscopy. So here also we send the patient for endoscopy. Endoscopy, this is the first investigation done. Clear? And when we perform endoscopy, we can perform endoscopic varicose ligation or endoscopic sclerotherapy. So here you can see how it's done. This is the bleeding varices and I'm going to ligate it. So this is endoscopic varicose ligation, and here you are going to inject the sclerosing agent around the varices. This is endoscopic sclerotherapy. So this one is endoscopic sclerotherapy. Which one is the treatment of choice or which one is preferred? Obviously, endoscopic varicose ligation is preferred over endoscopic sclerotherapy. Why? Because endoscopic sclerotherapy can lead to esophageal perforation or it is having increased risk of complication. So preferred is endoscopic varicose ligation. After that, in all patients, we have to start antibiotics, and antibiotics are given for 7 days. Right? So this is how we manage the patients of varicose bleeding. Sometimes even after endoscopic varicose ligation, when the bleeding is controlled, there is rebleeding. And if rebleeding occurs, what should be done? In cases of rebleeding, we have to perform repeat endoscopy. Imagine there is rebleeding. In this case, we have to perform the repeat endoscopy. Repeat endoscopy. Suppose 2 attempts of endoscopy are failed to control the bleeding. So that is known as failed endoscopy. And when 2 attempts are not able to control the bleeding, in that case we can go for surgical intervention. And what you can do in such cases, either we can go for TIPS or we can go for shunt. When 2 attempts of endoscopy are not able to control the bleeding. Suppose we want to control the bleeding during transportation, we can use this Sengstaken-Blakemore tube. In short, it is also known as SB tube. Sengstaken-Blakemore tube, it is used to control bleeding during transportation. But see, maximum you can use this tube for 24 hours. And every 12 hourly you have to decompress this esophageal balloon. How much pressure it is going to exert? It is going to exert the maximum pressure of 35 to 40 mmHg. Clear? At the time of insertion, since the stomach is full and most of the patients are in the state of shock, what is the most common complication of insertion of Sengstaken-Blakemore tube? Yes, it is aspiration. So since aspiration is the most common complication, what should be protected during insertion? Airway should be protected during insertion of Sengstaken-Blakemore tube. See this diagram, this is left-sided portal hypertension, and what is the other name of left-sided portal hypertension? That is sinistral hypertension. What is the most common cause? You can see here, this is the pancreas. So it is acute pancreatitis, and because of this acute pancreatitis, what is the problem? Here you can see there is splenic vein thrombosis. So in left-sided portal hypertension, what is the problem? Most common cause is acute pancreatitis. Because of that, there is splenic vein thrombosis, and because of this splenic vein thrombosis, you can notice it can lead to splenomegaly. This is what? Splenomegaly. And because of this splenic vein thrombosis, what happens? Here you can see there are formation of gastric varices along short gastric vessels. So because of this, there is formation of gastric varices. Gastric varices. Simple. And what is the treatment of choice? Obviously, we go for what? Splenectomy. So the treatment of choice for left-sided portal hypertension, that is splenectomy. Now in this diagram, what you can see, that there is a placement of stent. This is the stent, and there is placement of stent between which structure? This is right hepatic vein, and here you can see this is the right branch of portal vein. So here there is placement of stent between right hepatic vein and right branch of portal vein. This is TIPS, transjugular intrahepatic portosystemic shunt. It is a kind of non-selective shunt. So this is a type of non-selective shunt, and in this case we are going to insert the stent between right hepatic vein and right branch of portal vein. So what is the name of stent inserted? This is Viator. Viator. And what is the preferred vein for cannulation? The preferred vein for cannulation is right internal jugular vein. So this is right internal jugular vein, which is preferred vein for cannulation. Now see the problem here. In this case, what will happen? The blood from portal vein start going into hepatic vein, and from that it enters into IVC. It means directly the blood from portal vein goes into hepatic vein and then into IVC. Because of this, there is increased venous return to the heart. So any condition in which there is already load on the right heart, that will be an absolute contraindication. One point. Second point, you know that urea synthesis occurs in the liver. So here detoxification of ammonia into urea is not taking place. So high concentration of ammonia also enters into systemic circulation. So what is the most common complication because of this high ammonia? That is encephalopathy. So the most common complication of TIPS, and this is encephalopathy. Encephalopathy. Simple. So first see what are the contraindications, and then we will discuss the indications. So any situation in which there is already load on the right heart, like right heart failure, pulmonary hypertension, hepatopulmonary syndrome, and polycystic liver disease. Why? Because anatomy is distorted in polycystic liver disease. Now see the relative contraindications. The relative contraindications are portal vein thrombosis, hypervascular liver tumor, and you know the most common complication was encephalopathy. So if patient is already having encephalopathy, this is a relative contraindications. You know, most common complication of TIPS is encephalopathy. So if patient is already having encephalopathy, this is a relative contraindication. Now we are going to discuss the indications. It's easy to remember indications. Any situation in which portal pressure is increased, because of TIPS we are going to decrease the portal pressure. So all those situations are going to improve. First, what is the most common indication? It is the prevention of variceal rebleeding. Other indications are acute variceal bleeding. If patient is having refractory ascites, there is refractory hepatic hydrothorax, hepatorenal syndrome. In patients of Budd-Chiari syndrome, veno-occlusive disease, we can go for TIPS. And in portal hypertensive gastropathy also, there is increased portal pressure. You perform TIPS and patient is going to improve. So these are indications. What is the question which is asked in exam? What happens? They ask you about the indications and absolute contraindications. And what you have to notice here, that absolute contraindication is hepatopulmonary syndrome. Hepatopulmonary syndrome is an absolute contraindication. But see, hepatorenal syndrome is an indication. You have to remember this because in exam, hepatorenal syndrome looks like hepatopulmonary syndrome. So you have to remember hepatopulmonary syndrome is an absolute contraindication. Hepatorenal syndrome is an indication for TIPS. Now we are going to discuss the shunt. Shunts are of three types: non-selective, selective and partial. Non-selective means non-selectively almost whole blood of portal vein is going into systemic circulation. Selective means a selected region is being drained, and partial means any shunt in which the diameter of shunt is less than 1 centimeter or 10 mm. So there is partial migration of blood flow, that is partial shunt. See the types first. The shunts included in non-selective shunt, one is EC fistula, second is SSPCS, the full form is side to side portocaval shunt. Third is interposition graft. Interposition graft means you are going to put a graft between two vessels. So one is portocaval, second is mesocaval, and third is mesorenal. And another type is PSRS, the full form is proximal splenorenal shunt. And what is the other name? This is also known as Linton's shunt. Proximal splenorenal shunt, that is also known as Linton shunt. What is selective shunt? This is DSRS, full form distal splenorenal shunt, and who made it for the first time? Warren. That's why it is also known as Warren shunt. And the second type is Inokuchi shunt. Second type, that is Inokuchi shunt. Simple. And partial shunt, whenever the diameter of shunt is less than 10 mm. These are the types of shunt. What we are going to do in EC fistula, we are going to divide the portal vein. So here you are going to divide, and this part is anastomosed to IVC. So here you can see this is ligated and this part is anastomosed to IVC. So this is portal vein and this is IVC. So what kind of anastomosis is done? End to side portocaval shunt. This is obsolete. Why? Because of increased risk of complication. So this is EC fistula. Nowadays it is obsolete, means it's not done because of increased risk of complications. See this diagram, this is side to side portocaval shunt. So one side of portal vein is anastomosed to one side of IVC. So here you can see one side of portal vein is anastomosed to one side of IVC. So this is side to side portocaval shunt, and this is most commonly performed shunt worldwide. And side to side portocaval shunt, it is the shunt of choice for refractory ascites, Budd-Chiari syndrome and veno-occlusive disease. So this is most commonly performed shunt worldwide, shunt of choice for refractory ascites, Budd-Chiari syndrome and veno-occlusive disease. Now see this diagram. This is kidney, this is spleen, and this vein is left renal vein. This is left renal vein, this is IVC. Interposition graft means the graft is applied between two vessels. So here, if it is being applied, or we are going to use one interposition graft between portal vein and vena cava, what should be the name? This is portocaval. If it is between superior mesenteric vein and vena cava, this is known as mesocaval. And if it is between superior mesenteric vein and renal vein, obviously it is mesorenal. So portocaval, mesocaval, mesorenal. And what is the direction of blood flow? You can see this is the direction of blood flow, and in this case this is the direction of blood flow. So all these are interposition grafts. Now see this diagram. This is proximal splenorenal shunt, also known as Linton shunt. What we are going to do here, this is the splenic vein. Okay, this is the original diagram. This is the proximal part of splenic vein, this is the distal part. So I'm going to divide this proximal part. So you ligate this proximal part, and when you ligate this proximal part, obviously you have to perform splenectomy. So after performing splenectomy, I'm going to suture this proximal part of splenic vein to the renal vein. And here you can notice that this is the direction of blood flow. So this is proximal splenorenal shunt. This is the distal splenorenal shunt, and who made it for the first time, or who performed it for the first time? Warren, and that's why it is also known as Warren shunt. Here you can see this is the splenic vein, this is the proximal part, this is the distal part. So after ligating the distal part, you can notice that it is being anastomosed to the renal vein, and that's why this is the direction of blood flow, distal splenorenal shunt. So here you can notice that only splenic system is getting decongested here. So it is a kind of selective shunt, distal splenorenal shunt, that is also known as Warren shunt. Next shunt is Inokuchi shunt. How to remember first? Mnemonic is IVC. I means interposition graft between vena cava and C means coronary vein. What is the other name of coronary vein? It is also known as left gastric vein. So it is interposition graft between vena cava and coronary vein, which is also known as left gastric vein. Here you can see that there is portosystemic anastomotic site between azygous vein and left gastric vein, and I am attaching one interposition graft from this left gastric vein to IVC. So can you see the direction of blood flow? This is the direction of blood flow. So this is Inokuchi shunt, and here you can notice that only GE junction is being decongested. So what kind of shunt is this? This is selective. So you have to remember distal splenorenal shunt and Inokuchi shunt. These are selective shunt because a selected region is being drained. So in this diagram you can see that one end of the shunt is placed in the peritoneal cavity and another end is connected to a vein. Which vein? In majority of cases right internal jugular vein, and in some patients superior vena cava. So one end into peritoneal cavity, another end into a vein, right internal jugular vein or superior vena cava. So what's the name of this shunt? Peritoneo-venous shunt. What are the names? Denver, Levine and Minnesota. These are the names for peritoneo-venous shunt. Denver, Levine and Minnesota. So in which patients we are using this peritoneo-venous shunt? The indication is refractory ascites. Peritoneo-venous shunt is used in refractory ascites, and the preferred vein is right internal jugular vein followed by superior vena cava. Another important topic is non-cirrhotic portal hypertension. So if you see, there are two components. One is non-cirrhotic, means there is no cirrhosis. So no ascites, no jaundice, no encephalopathy, no hepatic failure. And if there is portal hypertension, there are two components. What? Patients will be having esophageal varices and splenomegaly. So here, non-cirrhotic means no ascites, no jaundice, no encephalopathy, no hepatic failure, and there is portal hypertension. So two universal manifestations, esophageal varices, and what? There is splenomegaly. There is splenomegaly. So in such patients, the most common presentation is variceal bleeding, and the most common cause of death also is variceal bleeding. Why? Because there is no hepatic failure. What are two conditions we include? One is EHPVO, extrahepatic portal venous obstruction, and second is non-cirrhotic portal fibrosis. So what kind of clues you will get in the exam? There will be variceal bleeding and splenomegaly, but there is no ascites, no jaundice, no encephalopathy, no hepatic failure. What is Budd-Chiari syndrome? It is caused by hepatic venous outflow obstruction. Most common causes: hepatic vein thrombosis or IVC obstruction. IVC obstruction. So overall, most common cause, that is hepatic vein thrombosis. And one of the common cause of hepatic vein thrombosis is polycythemia vera. But see, in India, China, Japan and South Africa, the most common cause is IVC obstruction. In India, China, Japan and South Africa, the most common cause is IVC obstruction. In a latest exam, triad of Budd-Chiari syndrome was asked. So what is the triad of Budd-Chiari syndrome? How to remember? The mnemonic is ASHA. Ascites, hepatomegaly, abdominal pain. Triad is ASHA, ascites, hepatomegaly, abdominal pain. What is the investigation of choice? Here you can see there is hepatic vein thrombosis. So investigation of choice for diagnosis, and that is venography. That is venography. Now coming to the treatment. If there is hepatic vein thrombosis, what kind of treatment we can go for? Side to side portocaval shunt. Why? Because vena cava is patent. So in hepatic vein thrombosis, we can go for side to side portocaval shunt. And imagine if the patient is having IVC obstruction, if there is membranous obstruction, so we rupture that membrane via heart, transcardiac membranotomy. So if there is membranous obstruction, we can go for transcardiac membranotomy, that is transcardiac membranotomy. Or in cases of stenosis, we have another option, and that is excision with grafting. So for stenosis, we can go for excision with grafting. And what is the problem? Suppose there is delay in the presentation and patient is having hepatic failure. So in patients of hepatic failure, we go for liver transplantation. So liver transplantation for hepatic failure. One important concept we already discussed, what? In liver, that whenever Budd-Chiari syndrome is because of hepatic vein thrombosis, caudate lobe is spared. Because caudate lobe venous drainage goes directly into IVC. So over a period of time, the liver will be atrophied, but caudate lobe will be hypertrophied, and this hypertrophied caudate lobe on scintigraphy appears as central hotspot sign. Because of caudate lobe hypertrophy, on scintigraphy there is central hotspot sign. What is veno-occlusive disease? It is very similar to Budd-Chiari syndrome, that there is hepatic venous outflow obstruction, but here the etiology is different. So veno-occlusive disease is also because of hepatic venous outflow obstruction. And what is the cause? It is caused by endothelial sclerosis of sublobular hepatic vein or hepatic venules. Means these are the microscopic structures. What is the most common cause in Western countries? And the most common cause in Western countries, it is bone marrow transplantation. This is the most common cause in Western countries. Another cause is consumption of bush tea. And in the bush tea, there is one alkaloid. Which alkaloid? Pyrrolizidine. So there is presence of pyrrolizidine alkaloid. This pyrrolizidine alkaloid increases the risk of veno-occlusive disease. So almost the clinical features will be similar. Here also see what are the clinical features and what is the characteristic triad. The triad of veno-occlusive disease, it is easy to remember, and the mnemonic is THR. T means tender congestive hepatomegaly, R means hyperbilirubinemia or jaundice, and R means retention of fluid. So generally these patients are having ascites. Tender congestive hepatomegaly, there is hyperbilirubinemia or jaundice, retention of fluids. Now see, what is the investigation of choice? In this case, there is endothelial sclerosis. So we have to visualize this endothelial sclerosis. So investigation of choice for diagnosis, it is biopsy. So what's the investigation of choice for diagnosis? It is biopsy. And in veno-occlusive disease, IVC is patent. So what's the treatment? Generally we go for side to side portocaval shunt. And in cases of delayed presentation, when the patient is having hepatic failure, we have liver transplantation. So liver transplantation is done in the patients who are having hepatic failure. Okay. Apart from this, there are two important questions which are asked. One is MELD score and the second is PELD score. So what is the full form of MELD score? Model for end stage liver disease. Model for end stage liver disease. And how to remember the components? Mnemonic is CBI, creatinine, bilirubin and INR. CBI, creatinine, bilirubin and INR. And the PELD score, full form is pediatric end stage liver disease. And what's the mnemonic? NABIA, nutrition, age, bilirubin, INR, albumin. Nutrition, age, bilirubin, INR, albumin. So this is all about portal hypertension. Now we are going to discuss gallbladder. So first we are going to discuss anatomy and physiology. So gallbladder is pyriform in shape. What's the color? Sea green. It is thin and elastic. And how much is the content? Content is 30 to 50 ml. Content 30 to 50 ml, and it is lined by tall columnar epithelium. So what are the functions of gallbladder? It is storage, concentration and acidification of bile. How many times it concentrates bile? it is going to concentrate bile 5 to 10 times. 5 to 10 times. You know that there are two layers which are absent in gallbladder. What are those two layers? First, muscularis mucosa, and the second is submucosa. So important point, there are two layers which are absent. One is muscularis mucosa and submucosa. Muscularis mucosa and submucosa, these are absent in gallbladder. Okay. After that, you must be knowing that jejunum is having maximum absorptive capacity. Jejunum, it's having maximum absorptive capacity. So which organ is having maximum absorptive capacity per unit surface area? And that's gallbladder. So another important point, that gallbladder, it is having maximum absorptive capacity. Maximum absorptive capacity per unit surface area. And if we see overall maximum absorptive capacity, it is seen in jejunum. Now, if you see in the gallbladder, there is cystic duct, and in the cystic duct, there is spiral mucosal fold. What is the name of this spiral mucosal fold? This is known as spiral valve of Heister. So, what's the name? This spiral mucosal fold, it is known as spiral valve of Heister. One important point. Second, there is ill-defined sphincter. In the cystic duct, there is ill-defined sphincter. What's the name of this sphincter? This is known as sphincter of Lutyens. Name of this sphincter? Sphincter of Lutyens. So two important points. One, spiral valve of Heister and sphincter of Lutyens. These are not the part of gallbladder. These are part of cystic duct. Now see here. At the neck, there are tubulo-alveolar glands in the gallbladder. In the gallbladder at neck, there are tubulo-alveolar glands, and these tubulo-alveolar glands are going to secrete mucus. So if a large stone is impacted at cystic duct CBD junction, the gallbladder will be massively distended with mucus, and the name of this condition is what? Mucocele. Now we are going to discuss very important topic, gallstones. So here you can see, this is cholesterol gallstone, which is yellow colored. There is black stone, obviously black colored, and brown is brown colored. So these are the types of gallstone. Overall, which one is most common type? Yes, it is cholesterol gallstone. So we are going to discuss this cholesterol gallstone. Worldwide, this is the most common type of stone. So this is most common type of gallstone. See, the 95% component will be cholesterol, but 2 to 3% component will be black, or 2 to 3% component will be brown. So effectively saying that it is mixed. If mixed is there in the option, so choose mixed. So question, if most common type of gallstone is asked, you have to choose cholesterol if mixed is not given in the option, and if it's given, then choose mixed. Mixed. What is the composition of cholesterol gallstone? It is composed of crystalline, this is the latest question, crystalline cholesterol monohydrate. Crystalline cholesterol monohydrate. This is the latest question. So this is the composition of cholesterol gallstone. You must be knowing what is the composition of bile. In bile, 85 to 95% is water. It's water. And in 5 to 10% there is what? There is cholesterol, there is bile acid and lecithin. So there is cholesterol, there is bile acid and there is lecithin, right? You know that cholesterol is fat soluble. So how it is made water soluble in the bile? With the help of bile acid and lecithin. So this bile acid and lecithin with cholesterol leads to the formation of micelle. So there is formation of micelle, and this micelle is water soluble. Okay, so any condition in which there is increased concentration of cholesterol or decreased concentration of bile acid or lecithin, that is lithogenic bile. So there are three mandatory factors for cholesterol gallstones. First, lithogenic bile. Second, nucleation, and third, stasis. So see, what are the factors which leads to formation of lithogenic bile? Lithogenic bile is because of increased cholesterol or decrease in the concentration of bile acid or lecithin. Nucleation. This nucleation is promoted by, in nucleation, microcrystals are joined together to form macrocrystal, and this nucleation is promoted by what? Infections and mucin glycoproteins. So this infection and mucin glycoproteins, these are pro-nucleating factors. Now see, what are the factors which are going to promote stasis in the gallbladder? Stasis is because of prolonged fasting or prolonged TPN requirement. Even in pregnancy, because of progesterone, there is stasis. If you take octreotide, which is somatostatin analog, and you know somatostatin is universal switch off, so octreotide is also going to decrease the concentration of cholecystokinin. So there is stasis. OCPs containing progesterone can lead to stasis, and massive burns because of hypovolemia can lead to stasis. So all these are the factors which are responsible for formation of cholesterol gallstone, and there are three mandatory factors: lithogenic bile, nucleation, and stasis. Now pigmented stones, these are the most common type of stone in Asian population. First, see the black stone. This is the bilirubin pigment polymer. Black stones are bilirubin pigment polymer of what? Calcium phosphate and calcium bicarbonate. Calcium phosphate and calcium bicarbonate. Clear? So if in the stone there is calcium phosphate and calcium bicarbonate, black stone is obviously radio opaque and it is hard. So this black stone, it is radio opaque and this is hard. Black stones are hard. If you see the overall gallstones, 90% of gallstones are radiolucent, but black stone is radio opaque. And generally, in which conditions black stones are formed? These are seen in chronic hemolytic conditions. Chronic hemolytic conditions like hereditary spherocytosis, like prosthetic heart valve. Clear? So in chronic hemolytic conditions, there is increased risk of black stones. What's the composition of brown stone? It is composed of calcium bilirubinate, calcium palmitate, and calcium stearate. Calcium bilirubinate, calcium palmitate, and calcium stearate. Simple. Brown stones are more common in CVD and these are rare in gallbladder. In which particular population it is seen? It is more common in developing countries, especially in the low socioeconomic status. Why? Because of increased risk of worm infestation. So this is more common in CVD. These are rare in gallbladder. Rare in gallbladder, and it is more common in developing countries because of worms. So which worms? In India, Ascaris, and in China, it is Clonorchis sinensis. So because of worms, Ascaris and Clonorchis sinensis. There are three one-liner questions which are asked frequently. First, 90% of gallstones are radiolucent or radiopaque. So 90% of gallstones, these are radiolucent. 90% of renal stones are radioopaque, and 80% of salivary gland stones are also radioopaque. So 90% of kidney stones, these are radioopaque, and 80% of salivary gland stones, these are also radioopaque. These are also radioopaque. Now see, gallstones, sometimes they have triradiate fissure, and if there is triradiate fissure in the gallstone and you go for plain X-ray, what kind of appearance is seen? This is known as Mercedes-Benz sign. So in this image you can see, this is the Mercedes-Benz sign on plain X-ray, here and here. See again. So this is Mercedes-Benz sign. What kind of fissure is there? There is triradiate fissure. So if there is triradiate fissure on plain X-ray, you will find what? This Mercedes-Benz sign. This is Mercedes-Benz sign. Okay, and sometimes there is biradiate fissure. And if there is biradiate fissure, this sign is known as seagull sign. So here you can see this is the biradiate fissure and this appears as seagull. So this is known as what? Seagull sign. Now coming to the investigation of choice. In gallstones, the investigation of choice for diagnosis is ultrasound. And in acute cholecystitis, acute acalculous cholecystitis and chronic cholecystitis, in all these cases, investigation of choice for diagnosis is ultrasound. So see this important question. Investigation of choice for diagnosis of gallstones, acute cholecystitis, acute acalculous cholecystitis and chronic cholecystitis. In all these cases, investigation of choice is ultrasound. And what is the gold standard investigation for diagnosis of acute cholecystitis? The gold standard investigation for diagnosis of acute cholecystitis is HIDA scan. HIDA scan, what is the full form? Hepatobiliary immunodiacetic acid scan. Hepatobiliary immunodiacetic acid scan is the gold standard investigation. This is gold standard investigation for diagnosis of acute cholecystitis. Right? How it looks like? So in normal HIDA scan, here you can see that there is presence of tracer in gallbladder, in CBD as well as in small intestine. But in patients of acute cholecystitis, here you can see that there is no tracer in gallbladder, means there is non-filling of gallbladder. But you can see the tracer is there in CBD and small intestine. So it's the non-visualization of gallbladder within 30 minutes of HIDA scan, which is the diagnostic of acute cholecystitis. Non-visualization of gallbladder within 30 minutes of HIDA scan is diagnostic. Now we are going to discuss the complications of gallstone, and the complication of gallstone depends on the organ. So see, what are the complications in gallbladder? In gallbladder, it can be asymptomatic, there can be acute cholecystitis or chronic cholecystitis. Sometimes there is mucocele, and if it is infected, it can lead to empyema. There can be necrosis, perforation, and if gallstone is present for long duration, especially if the size is more than 3 cm, it can lead to carcinoma gallbladder. What is the problem in CBD? In CBD, it can lead to jaundice. And what's the problem in pancreas? It can lead to gallstone induced acute pancreatitis. There can be gallstone induced acute pancreatitis. What is the complication in small intestine? It can lead to gallstone ileus. This is gallstone ileus. So these are the complications of gallstone in relation to the organs. Now we are going to discuss biliary colic and what is the difference between biliary colic and acute cholecystitis. Imagine a fat, fertile, flatulent female of 40 coming to you saying that, sir, on taking fatty food, I'm having pain in right upper quadrant, which is of short duration of 4 to 6 hours, relieved on its own, and it is not associated with fever. That is biliary colic. So fat, fertile, flatulent female of 40 complains of pain in right upper quadrant, and it is precipitated by fatty food. Duration 4 to 6 hours, not associated with fever, and it is relieved on its own. But imagine a patient who is having cholecystitis, acute cholecystitis. She is having triad of right upper quadrant pain. There is fever, there is leukocytosis. Minimum duration of pain is 24 hours and it is not relieved on its own. So acute cholecystitis, it is characterized by triad of right upper quadrant pain, fever, leukocytosis. Minimum duration of pain 24 hours. It's not relieved on its own. There are two important signs which are asked. On pressing tip of right ninth costal cartilage, patient stops the breath or catches the breath in inspiration. What's the name of this sign? This is known as Murphy's sign. Important sign. That is Murphy's sign. It is also known as Nonin sign. Right? So what is this Murphy's sign? On pressing tip of right ninth costal cartilage, patient catches the breath in inspiration. Second sign, at the right inferior angle of scapula, there is hyperesthesia. So hyperesthesia at right inferior angle of scapula. And what's the name of that sign? That is Boas sign. These are two signs which are asked frequently. We discussed what is the investigation of choice for diagnosis of acute cholecystitis? Ultrasound. And what is the gold standard investigation for diagnosis? HIDA scan. So investigation of choice, ultrasound. Gold standard investigation, HIDA scan. Now the treatment depends whether patient presents within 72 hours of attack or after 72 hours of attack. So if patient comes within 3 days or within 72 hours, we go for conservative management, followed by in hospital or same sitting laparoscopic cholecystectomy. So followed by same sitting laparoscopic cholecystectomy. Clear? After 72 hours, the adhesions become vascular. There is increased risk of bile duct injury. So here we go for conservative management and we discharge the patient. We perform interval laparoscopic cholecystectomy. Interval lap chole. And this interval laparoscopic cholecystectomy is performed after 4 to 6 weeks. So you have to remember, interval lap cholecystectomy performed after 4 to 6 weeks. In both pathology as well as in surgery, this question is asked that what is the most common organism responsible for emphysematous cholecystitis? And this is Clostridium welchii or Clostridium perfringens. Clostridium welchii or Clostridium perfringens followed by E. coli. You know Clostridium welchii, it is an anaerobe, and E. coli, that is an aerobe. This is an aerobe. So what is the most common aerobic organism responsible for emphysematous cholecystitis? E. coli. And overall most common organism responsible, that is Clostridium perfringens or Clostridium welchii. In this image here you can see that there is gas within gallbladder wall or there is ring of air around the gallbladder. Can you see here? There is ring of air around the gallbladder. So gas within the gallbladder wall or ring of air around the gallbladder, this is seen in emphysematous cholecystitis. What about xanthogranulomatous cholecystitis? Xanthogranulomatous cholecystitis is a non-infectious condition. And what is the cause? This xanthogranulomatous cholecystitis is caused by rupture of Rokitansky-Ushoff sinuses. Rupture of Rokitansky-Ushoff sinuses. Clear? It's non-infectious condition caused by rupture of Rokitansky-Ushoff sinuses. Because of that, there is bile leak, and because of bile leak, there is xanthogranulomatous inflammation. What is acute acalculous cholecystitis? So here, cholecystitis means there is inflammation of gallbladder, and acalculous means there is no stone. So simple, there is inflammation of gallbladder in absence of stone. So stone is not responsible for inflammation. So what are the two factors which are responsible for acute acalculous cholecystitis? First is stasis, and the second is ischemia. So any factor which can lead to gallbladder stasis, like prolonged fasting, prolonged TPN requirement, that can cause acute acalculous cholecystitis, and any situation in which there is ischemia, like there is massive blood loss, massive fluid loss. Massive blood loss can be seen in long duration surgery like CABG, coronary artery bypass grafting, or aneurysm repair. So what is the cause of ischemia? It is caused by either massive blood loss or massive fluid loss. So massive blood loss occurs in long duration surgery like coronary artery bypass grafting, aneurysm repair, and massive fluid loss occurs in massive burns. So stasis and ischemia, these are the two factors which can cause acute acalculous cholecystitis. Now see the problem. This is the gallbladder, normal gallbladder. In acalculous cholecystitis, this gallbladder is massively distended. And since it is massively distended, there is increased risk of perforation. And what is the most common site of perforation? The most common site of perforation is fundus. Fundus is the most common site of perforation. So how we treat? In majority of patients of acute acalculous cholecystitis, the treatment of choice is lap cholecystectomy. It is laparoscopic cholecystectomy. But second problem, certain patients are unstable, admitted in ICU. So in such patients, we go for ultrasound or CT guided percutaneous insertion of pictal catheter, that is percutaneous cholecystostomy. So in this patient, you can see percutaneously what is inserted, pictal catheter. So in unstable patient of acalculous cholecystitis, what should be done? It is ultrasound or CT guided percutaneous, you have to remember this term, cholecystostomy. This is cholecystostomy. So in exam, you have to remember whether in exam treatment of choice is asked or in exam unstable patient is mentioned and then treatment is asked. So treatment of choice, lap cholecystectomy, in unstable patient, ultrasound or CT guided percutaneous cholecystostomy. Let me tell you, in almost all types of acute cholecystitis, what is the investigation of choice? Generally, it's ultrasound. And what is the gold standard investigation? HEDA scan. So in acute acalculous cholecystitis also, investigation of choice is ultrasound and gold standard investigation is HEDA scan. See this condition, this is gallstone ileus. So what is the problem? First, in the gallbladder, there is large stone. Because of this large stone, there is chronic inflammation, and what happens? It is going to erode the duodenum and the gallbladder. So there is formation of a fistula. So what is the most common fistula in gallstone ileus? The most common fistula is cholecystoduodenal. It is cholecystoduodenal. So in the diagram, you can see that by this cholecystoduodenal fistula, the stone is coming into the duodenum. So here is the stone. It is coming into the duodenum and then it is going to obstruct the narrowest part of small intestine, that is terminal ileum. Terminal ileum, so it can obstruct terminal ileum 30 centimeter or 60 centimeter from IC junction, or it can obstruct at IC valve. So what is the most common site of obstruction? Most common site of obstruction, it is generally terminal ileum. Terminal ileum, right? Gallstone ileus is generally seen in elderly, age group 6th to 7th decade, and since stone is obstructing the ileum, obviously patient will be having signs and symptoms of small bowel obstruction like colicky pain, multiple episodes of vomiting, non-passage of feces and flatus. And when you send this patient for X-ray, there is dilated bowel loops and you will notice the presence of ectopic gallstone. This is ectopic gallstone. And what else? By this fistula, there is presence of air in the biliary tree, that is pneumobilia. So what is the name of this triad? This is plain X-ray triad, Rigler's triad components, small bowel obstruction, ectopic gallstone and pneumobilia. So this question is asked many times, the components of Rigler's triad. It is seen in gallstone ileus. There is small bowel obstruction, ectopic gallstone, pneumobilia. How we are going to make the diagnosis? So the diagnosis is made by clinical findings plus ultrasound plus X-ray. Clinical findings plus ultrasound plus X-ray. We discussed that most of the patients are elderly. So that's why we have to what? Remove the obstruction. So give incision over small bowel, milk the stone proximally, remove it. So it's the enterotomy with removal of obstruction. Cholecystectomy is generally not done. It is done only if the patient is young and stable. So what's the treatment? Treatment is removal of obstruction only. This is the removal of obstruction only by enterotomy. cholecystectomy is not done. So question, in which patients we are going to perform cholecystectomy? If it is mentioned in the question that patient is young and stable. So in young and stable patients, we perform cholecystectomy also with removal of obstruction. This condition is adenomyomatosis. So what's the problem in adenomyomatosis? This is the gallbladder and there are hyperplastic changes in muscularis with mucosal hyperproliferation. Hyperplastic changes in muscularis with mucosal hyperproliferation. So the muscle layer is very thick and Rokitansky-Aschoff sinuses are very deep. In these Rokitansky-Aschoff sinuses, there is deposition of cholesterol crystal. So whenever we perform ultrasound, it appears like this. So here you can see, it looks like diamond ring sign, also known as comet tail artifacts, also known as V-shape artifacts. So what's the name of this particular sign? It was an image-based question. This is diamond ring sign, comet tail artifacts or V-shaped artifacts. So what is the treatment? See, if the patient is having gallstone and patient is having symptoms because of gallstone, that is symptomatic gallstones. So in such patients, we perform lap cholecystectomy. So here, what we do? We perform lap cholecystectomy in which patients who are having symptomatic gallstones. So for symptomatic gallstones, we perform lap cholecystectomy. Now we are going to discuss gallbladder polyp. It is of two types, cholesterol polyp and adenomatous polyp. Which one is more common? Cholesterol polyp. This is more common. Cholesterol polyps are benign, small. These are multiple and pedunculated. Whereas this adenomatous polyp, this is premalignant. This is premalignant. Generally, these are large, single and sessile. Sessile means the polyp is not having any stalk. Pedunculated means it is having a stalk. In adenomatous polyp, what are the factors which are going to increase the risk of invasive cancer? So if a patient is having adenomatous polyp and the age is more than 60, size of polyp is more than 1 centimeter, with polyp there is presence of gallstone or there is documented increase in the size of polyp on repeated scan. So if all these factors are there, these are going to increase the risk of invasive cancer in adenomatous polyp. This is the strawberry gallbladder. You can see it is looking like strawberry. It is also known as cholesterolosis. So what is the cause? It is caused by deposition of cholesterol. What? Ester. Here you can see. It is caused by deposition of cholesterol ester and triglyceride in epithelial macrophages of gallbladder. Cholesterol ester and triglycerides in epithelial macrophages of gallbladder. You know, this condition is acquired. This is acquired. This is benign. And it is associated with which stone? Cholesterol gallstone. Which polyp? Cholesterol polyp. And which condition? Hypercholesterolemia. So everything is related to cholesterol in strawberry gallbladder. So important point, it is associated with hypercholesterolemia, cholesterol gallstones and cholesterol polyp. Here also, in which cases we are going for laparoscopy cholecystectomy? If patient is having symptomatic gallstone. So in which cases we go for lap cholecystectomy? So lap cholecystectomy is done for the patients who are having symptomatic gallstones. So if the patient is having symptomatic gallstones, we go for lap cholecystectomy. In this image, you can see that gallbladder is calcified. Here you can see there is calcified gallbladder and this is known as porcelain gallbladder. So what is the name of this condition? This is porcelain gallbladder, also known as calcified gallbladder. This is calcified gallbladder. So what is the problem here? There is extensive calcium incrustation in the gallbladder wall. Extensive calcium incrustation in the gallbladder wall. So this is calcified gallbladder. Why it is known as porcelain gallbladder? Because the color is bluish, and when we try to cut this gallbladder during surgery, it is brittle in consistency. So what's the color of porcelain gallbladder? It is bluish in color and it is brittle in consistency. Brittle in consistency. Right? Generally, it is seen in 5th to 6th decade. 90% patients are having gallstones, but patients are asymptomatic. How many patients? 90% patients, they have gallstones, but these patients are asymptomatic. What is the problem with porcelain gallbladder? The problem is that it is having increased risk of malignancy, carcinoma gallbladder, and how much is the risk of malignancy is 6%. There is 6% risk of carcinoma gallbladder. Here patient is asymptomatic, so how you are going to make the diagnosis? It is diagnosed incidentally on either X-ray or CT, and you are going to find the calcified structure just below the liver. So it is diagnosed incidentally either on X-ray or on the CT. And when diagnosis is done, what's the treatment? Early lap cholecystectomy. So why we go for early lap cholecystectomy? Because there is increased risk of malignancy. Which one? Carcinoma gallbladder. Now we are going to discuss carcinoma gallbladder. First, see what are the risk factors for carcinoma gallbladder. First is choledochal cyst. Second, gallstone. Large gallstones. What should be the size? More than 3 cm. Obesity, primary sclerosing cholangitis, chronic typhoid carrier, and we discussed adenomatous polyp, it is pre-malignant, and porcelain gallbladder, we discussed that there is increased risk of carcinoma gallbladder. So these are the risk factors for carcinoma gallbladder. One important point, what? That smoking is not a risk factor. Smoking is not a risk factor for carcinoma gallbladder. If you see the whole GIT from esophagus till rectum and whole hepatobiliary pancreatic tract like HCC, cholangiocarcinoma and carcinoma pancreas, in all these malignancies, smoking is a risk factor. So I'm repeating, for all GI malignancies from esophagus till rectum and for all hepatobiliary pancreatic tract malignancies, smoking is a risk factor. Only exception, carcinoma gallbladder, where smoking is not a risk factor. And second thing you have to remember that alcohol, it's not a risk factor for carcinoma stomach. Not a risk factor for carcinoma stomach. So smoking is not a risk factor for carcinoma gallbladder. Alcohol is not a risk factor for carcinoma stomach. In detail, we are going to discuss carcinoma gallbladder. So maximum incidence of carcinoma gallbladder is seen in which country? It is seen in India followed by Pakistan. And generally, carcinoma gallbladder, it is more common in females. Which particular age? 6th to 7th decade. So more common in females, seen in 6th to 7th decade. It is lined by tall columnar epithelium. So malignancy arising from columnar epithelium. What is the most common type? The most common type, it is adenocarcinoma. And you know, if the malignancy is adenocarcinoma, there is a non-specific tumor marker. What is that non-specific tumor marker? It is CEA. This is non-specific tumor marker. What is the specific tumor marker? The specific tumor marker is CA19-9. CA19-9. And what is the chemotherapy regimen given in carcinoma gallbladder? That is gemcitabine. This is the gemcitabine plus cisplatin. This is the chemotherapy regimen. Okay. What is the most common site? So if you see the most common site, this is fundus, followed by body, followed by neck. How much? 60% fundus, 30% body, and 10% neck. So most common site is fundus. After that, what is the route of spread? How to remember? Mnemonic is HELP. It is HELP hepatic, followed by lymphatic, followed by perineural. Hepatic, followed by lymphatic, followed by perineural. So most common route of spread is direct hepatic invasion. There is direct hepatic invasion, simple. And which segment of liver is involved most commonly? It is 4B and 5. So segment 4B and 5 are most commonly involved, and that's why when we perform extended cholecystectomy, we perform the removal of segment 4B and 5. Coming to the clinical features, so these patients are having repeated attacks of biliary colic, right? What else? There is increased frequency of attack when carcinoma gallbladder is there. There is increased severity of pain during attack with sudden change in the character of pain. And what is sudden change in the character of pain? There is persistent dull aching pain. So there is persistent dull aching pain. Since malignancy is there, these patients are going to develop what? Anorexia and weight loss. So the patients are going to develop anorexia and weight loss. Whenever we are going to perform the palpation, the gallbladder is replaced by a mass, and the mass is hard. What is the first investigation done? Ultrasound. And what is the investigation of choice in carcinoma gallbladder? CCT. So two important points. First investigation done, that is ultrasound. And what is the investigation of choice for diagnosis? That is CCT. Right? Staging of carcinoma gallbladder is very, very important. It was asked many times, you have to remember. So see, 8th AJCC TNM classification for carcinoma gallbladder. First, T staging. So what is T1A? There is involvement of lamina propria. And you know, just below lamina propria there is muscularis mucosa. Just below muscularis mucosa there is submucosa. But muscularis mucosa and submucosa are absent in gallbladder. That's why from T1A to T1B, we are jumping from lamina propria to muscularis propria, you have to remember. So T1A, involvement of lamina propria. T1B, involvement of muscularis propria. In T2A, there is involvement of perimuscular connective tissue towards peritoneal side without any serosal perforation. And what is T2B? Involvement of perimuscular connective tissue towards hepatic side without direct hepatic invasion. So what is included in T3? If there is serosal perforation or direct hepatic invasion or involvement of single extra hepatic organ. And in T4, if there is involvement of portal vein or hepatic artery or two or more extra hepatic organs. So this is T staging. Have a look of lymph node staging. In lymph node staging, N1 is metastasis to 1, 2, 3 regional lymph nodes, and in N2 there is metastasis to 4 or more regional lymph node. And easiest is M0. M0 means there is no metastasis, and M1. M1 means there is distant metastasis. There is distant metastasis. So this is TNM classification. You have to remember the staging also. See the staging. Stage 1A is T1A, 1B is T1B, 2A is T2A, 2B is T2B. So how to remember? If you apply T here, can you see T1A? So 1A is T1A, 1B is T1B, 2A is T2A, 2B is T2B, 3A is T3. And when first lymph node comes, it becomes 3B. So T1 to T3, N1, that is 3B. 4 is further divided into 4A, 4B. In 4A, there is T4, N0 to 1. And in 4B, T any N2 or T any N any M1. So how to remember? You can see here. These are the characteristic features of the stages. If it is M1 or N2, it becomes 4B. If it is T4, it becomes 4A. And if first lymph node comes, it becomes 3B. Simple. Otherwise, whatever is this side, it is on that side. 1A is T1A. So this is the staging. Now, for which of the following stages laparoscopic cholecystectomy is sufficient? So lap chole, it is sufficient for stage 1A or T1A. For stage 1B, to 3B, we go for extended cholecystectomy. We go for extended cholecystectomy, right? And for stage 4A, we go for extended cholecystectomy plus extended right hepatectomy. Extended cholecystectomy plus extended right hepatectomy. And if the stage is 4B, we go for palliation. So generally we give chemotherapy. Palliation by chemotherapy, what is the agent? Gemcitabine plus cisplatin. Now, what are the lymph nodes and what are the structures which are removed in extended cholecystectomy? So in extended cholecystectomy, we are going to remove segment 4B and 5 of liver plus gallbladder. Apart from this, lymph nodes. So in extended cholecystectomy, which lymph nodes are removed? Lymph nodes located along cystic duct, along CBD. CBD means pericholedochal lymph node. Around portal vein, that is periportal, and behind pancreas, that is retropancreatic. So these are the 4 groups of lymph nodes removed. So in extended cholecystectomy, we remove segment 4B and 5 of liver plus gallbladder plus lymph nodes along cystic duct, CBD, periportal and retropancreatic. We discussed that we perform cholecystectomy when the patient is having symptomatic gallstone. Gallstones with symptom. If patient is just having gallstone but no symptoms, and then also we are performing the cholecystectomy, or patient is not having gallstone, in future there are chances of development of gallstones with complications, we are performing cholecystectomy. This is known as prophylactic cholecystectomy. So what are the indications of prophylactic cholecystectomy? The indications are heart transplant recipient and lung transplant recipient. Why? Because we give cyclosporin as immunosuppressive agent, and because of this there is increased risk of gallstone formation. If there is prolonged TPN requirement, biliopancreatic diversion, here also there is increased risk of gallstone. If there is gallstone more than equal to 3 centimeter, it is going to increase the risk of complication. Chronic hemolytic conditions, chronic typhoid carrier, trauma to gallbladder, all these are indications. If it is non-functioning gallbladder, there are high chances that stones will be formed. Adenomatous polyp with stone, it is going to increase the risk of malignancy. Porcelain gallbladder, it is going to increase the risk of carcinoma gallbladder. And incidentally detected gallstone during elective surgery, because it is not having added morbidity of surgery. And if there is gallstone in the relative of carcinoma gallbladder patient, because there are increased risk of carcinoma gallbladder. So all these are indications of prophylactic cholecystectomy. And what you have noticed that diabetes mellitus, it's not an indication. Diabetes mellitus is not an indication for prophylactic cholecystectomy. Why? Because the incidence of acute cholecystitis in diabetes mellitus is similar to the normal population. But complications, rate of complication is more, but incidence is same. That's why we are not going for prophylactic cholecystectomy in diabetes mellitus. There are one-liner questions which are asked: who performed first lap cholecystectomy? And it was performed by Eric Muhe. Eric Muhe. Who performed first video-assisted laparoscopic cholecystectomy? It was performed by Philip More. Philip More. And who performed first laparoscopic appendectomy? It was performed by Kurt Sim. Kurt Sim. So this completes the gallbladder. Now we are going to discuss bile duct, and first of all we are going to discuss choledochal cyst. Choledochal cyst is characterized by dilatation of bile duct. It is more common in females. It is more common in children. It is a congenital condition. Choledochal cyst is congenital condition. Okay. What is the most accepted hypothesis for choledochal cyst? It is abnormal pancreatico-biliary duct junction. So most accepted hypothesis is abnormal pancreatico-biliary duct junction. There is a classification system for choledochal cyst. It is Todani modification of Alonso-Ledge classification. So this is Todani modification of Alonso-Ledge classification. What is type 1? In type 1, there is dilatation of extrahepatic bile duct. So here you can see, in type 1, there is dilatation of extrahepatic bile duct. What happens in type 2? In type 2, you can notice that there is diverticular dilatation. So in type 2, there is diverticular dilatation. What happens in type 3? There is dilatation of intraduodenal part of bile duct, and that's why it is also known as choledococele. So here you can see this part is dilated. So type 3, that is also known as choledococele, in which there is dilatation of terminal part of or intraduodenal part of bile duct. What happens in type 4? There are multiple cysts involving both intrahepatic as well as extrahepatic bile duct. So here you can see there are multiple cysts involving both intrahepatic bile duct as well as extrahepatic bile duct. This is type 4A. In type 4B, there are multiple cysts involving only extrahepatic bile duct. And what is type 5? Here, there are multiple cysts involving only intrahepatic bile duct, and this type 5 is also known as involvement of only intrahepatic bile duct. It is also known as Caroli's disease. This is Caroli's disease. These are the 5 types. Now see, what's the treatment? There is a basic principle we follow in surgery that intrahepatic bile duct cannot be repaired, and any condition in which there is involvement of intrahepatic bile duct, what is the treatment of choice? It's the liver transplantation. So in these 5 types, you can see that type 4A, where intrahepatic bile duct is involved, type 5, in these 2 types we go for liver transplantation. So what are the other conditions in which intrahepatic bile duct is involved? Like primary biliary cirrhosis, in which there is only involvement of intrahepatic bile duct; primary sclerosing cholangitis, in which there is involvement of both intrahepatic and extrahepatic bile duct. So in all these cases, we go for liver transplantation. So what are the conditions in which there is involvement of intrahepatic bile duct? Intrahepatic bile duct, and the treatment of choice is liver transplantation. So this is primary biliary cirrhosis, primary sclerosing cholangitis, type 4A and type 5. Simple. Second, what is the most common type of choledochal cyst? Generally in surgery, if a classification starts with 1, 2, 3, 4, 5, generally most common type is type 1. And if classification starts with A, B, C, D, E, what is the most common type? Type A. So in most of the classifications, you will see that the most common type is type 1. So here also, most common is type 1, followed by type 4, followed by type 3. So type 1, it is the most common. So what are the conditions in which type 1 is most common? So we discussed in choledochal cyst, type 1 is most common, in hiatus hernia, in gastric ulcer, in fistula in ano, and posterior urethral valve. In all these cases, type 1 is most common. Now coming to the treatment. So here you see, whenever there is involvement of extrahepatic bile duct, we are going to excise that extrahepatic bile duct. So in type 1, in type 2, and in type 4B, we are going to excise the extrahepatic bile duct and go for hepaticojejunostomy. So for type 1, for type 2, for type 4B, it is Roux-en-Y hepaticojejunostomy. For type 4A and 5, we discussed it is liver transplantation. And for type 3, it is endoscopic sphincterotomy with cyst unroofing. So for type 1, type 2, type 4B, we go for Roux-en-Y hepaticojejunostomy. Clear? So we excise extrahepatic bile duct and we go for Roux-en-Y hepaticojejunostomy. For type 4A and 5, there is involvement of intrahepatic bile duct, so we go for liver transplantation. And type 3, we go for endoscopic sphincterotomy. This is endoscopic sphincterotomy plus cyst unroofing. Clear? This is the treatment. Now coming to the clinical features. Choledochal cyst is characterized by mass, pain and jaundice And what kind of jaundice? There is intermittent jaundice. So in choledochal cyst, there is mass, pain and jaundice. This is the triad. And what kind of jaundice is seen? There is intermittent jaundice. There is intermittent jaundice. Simple. If a child age is less than 2 years, what is the most common symptom? It is jaundice. And if the age is more than equal to 2 years, in that case, it is abdominal pain. Now see the complications. This is the choledochal cyst. This is the cyst. Inside cyst, there is formation of stone. So that is cystolithiasis. Because of this stone, there is infection, that is cholangitis. And when the stone is going to obstruct pancreatic duct, it can lead to pancreatitis. And in this diagram, there are 5 organs. So choledochal cyst is going to increase the risk of all these 5 organ malignancies. So in choledochal cyst, there is increased risk of malignancy of liver, gallbladder, bile duct, pancreas as well as duodenum. And the maximum risk is seen for the bile duct. What is the most common site of malignancy? It is the posterior wall of the cyst. Posterior wall of the cyst. So there is increased risk of malignancy of all these organs. Most common site of malignancy, bile duct, means cholangiocarcinoma, and the most common site is posterior wall of cyst. What is the investigation of choice for diagnosis? Investigation of choice for diagnosis is MRCP, and we already discussed the management of choledochal cyst. Now we are going to discuss CBD stone, which is also known as choledocholithiasis. There are 2 types of CBD stone. First, retained stone, and there is recurrent stone. It can be retained or it can be recurrent. Okay, retained stones are detected within 2 years of cholecystectomy. Recurrent stones are detected after 2 years of cholecystectomy. So retained, it is detected within 2 years of cholecystectomy, and recurrent stones, these are detected after 2 years. After 2 years of cholecystectomy. There is another classification. It is further divided into primary CBD stone and secondary CBD stone. What is primary CBD stone? Whenever the stone is formed in CBD. If stone is formed in CBD, that is primary. And whenever stone is formed in gallbladder and then slips into CBD, that is secondary. So another type, primary and secondary CBD stone. Clear? So this primary CBD stone which is formed in CBD, generally it is brown, more common in developing countries. Why? Because of worm infestation. In developing countries, why? Because of worm infestation. And secondary CBD stone formed in gallbladder slips into CBD. So generally this is cholesterol stone. These are cholesterol stones, and these are seen in developed countries. Developed countries. Simple. See, there are 2 manifestations of CBD stone. Either patient is asymptomatic with raised laboratory parameters. So what is raised? There is raised ALP, raised GGT, raised 5-nucleotidase. So because of obstruction, what are the parameters which are raised? Alkaline phosphatase, gamma glutamyl transpeptidase and 5-nucleotidase. So either patient can be asymptomatic with elevation of these parameters, or patient can be symptomatic. There is jaundice with or without complications. There is with or without complications. Right? So what kind of complications? You can see there is stone in CBD. Because of this, there is obstruction. So there is jaundice. There can be infection leading to cholangitis. There can be cholangitis. If it's coming down, obstructing the pancreatic duct, there is pancreatitis. And for long duration, if the stone is there, what's the problem? Increased risk of cholangiocarcinoma. What is the investigation of choice for CBD stone? You know, it is MRCP. And what is the gold standard investigation? ERCP. Why? Because ERCP is both diagnostic and therapeutic. So you can see the picture. These are the stones, and this investigation is MRCP. And here you can see these are the stones. Clear? Multiple stones are there. This is ERCP. So this MRCP, it is the investigation of choice for diagnosis of CBD stone, and ERCP, this is the gold standard. Why? Because it is diagnostic as well as therapeutic. So what's the maximum size of stone which can be removed by ERCP? Maximum size of stone removed is 1.5 centimeter. So see how we manage CBD stones. Whenever the stone is up to 1.5 centimeter, we are going to remove it with ERCP. If the size is more than 1.5 centimeter, then we perform choledochotomy. Choledochotomy means incision over bile duct and remove the stone. And if there is distal obstruction, so apart from choledochotomy, we have to perform choledochoduodenostomy. Choledochoduodenostomy if there is distal obstruction. So this is how we manage CBD stones. For cholangitis, there are two mandatory factors. One is obstruction and second is infection. So mandatory factors are obstruction and infection. Clear? So what is the most common organism responsible for cholangitis? Obviously it is E. coli followed by Klebsiella. So most common organism, that is E. coli. Anything which can obstruct CBD that can lead to cholangitis. So what are the predisposing factors? So here you can see the predisposing factors are CBD stone. This is the most common cause of cholangitis. Others are biliary strictures, choledochal cyst, worms infestation. See, the most characteristic symptom of cholangitis, it is chills. And it is characterized by a triad. Which triad? Charcot's triad. So cholangitis CH, chills CH, Charcot's triad CH. So important point, there is chills. Important point, there are chills. Chills, that's the most characteristic symptom. It is characterized by a triad, that's Charcot's triad. What are the components of Charcot's triad? There is pain, there is jaundice, there is fever. If there is delay in treatment or there is inadequate treatment, it can lead to Raynaud's pentad. So here you can see delay in treatment, or if there is inadequate treatment, it can lead to Raynaud's pentad. So there is Charcot's triad, there is shock, and there is mental status changes. Charcot's triad, shock, mental status changes means whenever the patient is coming to your emergency, most of the patients are having what? They have shock. Clear? So at the time of presentation, what we have to give IV fluids and IV antibiotics, and majority of patients are going to improve. So we give IV fluids plus IV antibiotics, and most of the patients are going to improve. Clear? Imagine if there is no improvement, it means obstruction is still there. That's why infection is not clear. So if there is no improvement, we go for what? ERCP plus stone removal if there is a stone removal, or if there is stricture, we go for stenting. Imagine still there is no improvement. In that case, or it's not available or failed, we go for PTC plus stone removal or stenting. Imagine this is also not available or failed. So last option is what? Open biliary decompression. So we perform open biliary decompression, and when we perform open biliary decompression, we insert the T-tube also. So imagine there was a large stone impacted here, and you are giving incision, and you are going to remove the stone. This was open biliary decompression, and after that we are going to insert a tube, that is T-tube, right? After T-tube insertion, on 7th to 10th day, you are going to inject contrast. This is known as what? T-tube cholangiogram. So on which day T-tube cholangiogram is done? 7th to 10th day. Important point. So we perform T-tube cholangiogram on 7th to 10th day. Clear? Imagine you are going to perform T-tube cholangiogram and there are distal filling defects. It means there are stones are there. In that case, you have to retain the T-tube. So if there are distal filling defects, what? Retain the T-tube. Retain for 4 to 6 weeks. For 4 to 6 weeks. And we are going to remove the stone percutaneously. Percutaneous extraction of stone is done by which technique? Burhin's technique. So percutaneous extraction of stones are done by Burheen's technique. Clear? So you have to remember on which day T-tube cholangiogram, 7th to 10th day. For how long we have to retain the T-tube? 4 to 6 weeks. By which technique we are going to remove the stone? Burheen's technique. Incidence of bile duct injury. In open cholecystectomy, this is 0.1 to 0.2%, and in lap cholecystectomy, this is 0.3 to 0.85%. It means there is increased risk of bile duct injury in laparoscopic cholecystectomy. Which part of bile duct is most commonly injured in laparoscopic cholecystectomy? It is common hepatic duct. Common hepatic duct is most commonly injured, or is the proximal part of bile duct. Most commonly injured part, common hepatic duct or proximal part of bile duct. There is a classification system for biliary stricture. So after bile duct injury, there is formation of stricture. What's that classification? It is Bismuth classification of biliary strictures. So what's this Bismuth classification for biliary stricture? Imagine this is the common hepatic duct and here is the injury. So what? This common hepatic duct stump is more than 2 cm. This is type 1. Here it is less than 2 cm. So this is type 2. Here there is hilar stricture with intact confluence. This is type 3. And hilar stricture with destroyed confluence. This is type 4. So this is type 3. This is type 4. And whenever there is stricture involving aberrant right sectoral duct with or without stricture of common hepatic duct, that's type 5. So once again, common hepatic duct stump more than 2 cm, type 1, less than 2 cm, type 2, hilar stricture with intact confluence, type 3, hilar stricture with destroyed confluence, that is type 4, and the stricture involving aberrant right sectoral duct with or without stricture of common hepatic duct, that's type 5. But what is the problem with this classification? There is no information related to bile leak. That's why there is a better classification system. And what's that? Strasbourg classification. So in Strasbourg classification, what is type A? There is cystic duct stump leak or leak from subvesical duct of Lashka. This is the most common type. Type A, most common type. There is cystic duct stump leak or leak from subvesical duct of Lashka. In type B, there is occlusion of aberrant right sectoral duct. In type C, you can see there is transaction without occlusion. So there is bile leak. Type C, transaction without occlusion of aberrant right sectoral duct. In type D, you can see here there is lateral injury to common hepatic duct. And what is type E? It is E1 to E5 Bismuth classification. So here you can see E1 common hepatic duct stump more than 2 cm, E2 less than 2 cm, E3 hilar stricture with intact confluence, E4 hilar stricture with destroyed confluence, and E5 stricture involving aberrant right sectoral duct with or without stricture of common hepatic duct. So this is Strasbourg classification for laparoscopic bile duct injuries, which is preferred over Bismuth classification. See the important autoimmune disorders related to surgery. First, what are the important points related to autoimmune disorders? That generally these are associated with autoantibodies. Autoantibodies, it means you can make the diagnosis by the presence of autoantibodies. Second, generally these are more common in females. Okay, so tell me, what are the autoantibodies in primary biliary cirrhosis? There is anti-mitochondrial. What kind of autoantibody? There is anti-mitochondrial autoantibody. What kind of autoantibody is there in Graves' disease? LATS. LATS is long-acting thyroid stimulator. So this is thyroid stimulating autoantibody against which receptor? TSH receptor. Against TSH receptor, long-acting thyroid stimulator. And what is the autoantibody in Hashimoto's thyroiditis? Anti-TPO, full form anti-thyroid peroxidase. And in pernicious anemia, the autoantibodies are against which cells? Autoantibodies against parietal cells. Against parietal cells. Simple. So see, out of primary biliary cirrhosis and primary sclerosing cholangitis. Which one is autoimmune? Primary biliary cirrhosis, and primary biliary cirrhosis is more common in females. Primary sclerosing cholangitis, it's more common in males. So primary sclerosing cholangitis, primary means there is unknown etiology. Sclerosing means there are multiple strictures involving intrahepatic bile duct plus extrahepatic bile duct, and these patients have recurrent attacks of cholangitis. We discussed that this is more common in males and it is associated with ulcerative colitis, and you know that smoking is protective. Here, smoking is protective for both ulcerative colitis as well as for primary sclerosing cholangitis. In this image, you can see that there are multiple strictures involving both extrahepatic as well as intrahepatic bile duct. So intrahepatic as well as extrahepatic bile duct both are involved, and there are cells lining the cholangiocytes. What are these cells lining the cholangiocytes? These are the target cell of injuries. So these are cholangiocytes, cells lining the bile duct. These are the target cell of injury. Because of primary sclerosing cholangitis, there are multiple stricture, and if you take the cut section of multiple stricture, this kind of appearance is seen. And what is this kind of appearance? There is onion skin appearance. There is onion skin appearance. If you see the appearance on cholangiography like ERCP or MRCP, so there is beaded appearance of bile duct, and there is selective destruction of terminal intrahepatic branches, and that's known as pruned tree appearance. There is pruned tree appearance because of selective destruction of terminal intrahepatic bile duct. What's the problem? Because of these multiple strictures, obviously there is formation of stone, and because of this stone, there is obstruction, there is cholangitis, there is stricture leading to cholangitis. This stone is going to obstruct what? Pancreatic duct, so there is pancreatitis. Because of chronic inflammation, there is increased risk of cholangiocarcinoma. So cholangitis, there is jaundice, acute pancreatitis, increased risk of cholangiocarcinoma. What is the investigation of choice for diagnosis? You know that MRCP, and the gold standard investigation, which is both diagnostic and therapeutic. So this is ERCP because it is diagnostic and therapeutic, and since there is involvement of intrahepatic bile duct, obviously what is the treatment of choice? There is liver transplantation. So liver transplantation is the treatment of choice for primary sclerosing cholangitis. Here you can see this is the appearance of primary sclerosing cholangitis on MRCP and on ERCP. So you can notice there are multiple strictures involving both intrahepatic as well as extrahepatic bile duct. Primary biliary cirrhosis, it is characterized by destruction of intrahepatic bile ducts only. Destruction of intrahepatic bile ducts only. We discussed that it is autoimmune disorder, more common in females, and which autoantibody? Anti-mitochondrial. Anti-mitochondrial autoantibody. See the important questions related to pathology. So in primary biliary cirrhosis, there is florid duct lesion. What kind of inflammation? Granulomatous inflammation, and there is lymphocytic infiltration. These are the characteristic changes. That's why, what is the investigation of choice for diagnosis? Investigation of choice for diagnosis is biopsy. You can see all these changes. You can make the diagnosis by autoantibody, but investigation of choice for diagnosis is biopsy. In primary biliary cirrhosis, the two most characteristic symptoms are pruritus and fatigue. There is pruritus and fatigue. These are the two most characteristic symptoms, and pruritus precedes jaundice. So in clinical features, this is important. You have to remember that pruritus comes first. So pruritus precedes jaundice, and pruritus is most bothersome in evening. This is most bothersome in evening. Simple. So we discussed investigation of choice for diagnosis, biopsy. You can make the diagnosis by autoantibody, and since there is involvement of intrahepatic bile duct, what is the treatment of choice? the treatment of choice is liver transplantation. Now we are going to discuss cholangiocarcinoma. First, see the risk factors for cholangiocarcinoma. The risk factors are choledochal cyst, CVD stone, primary sclerosing cholangitis, ulcerative colitis, cirrhosis, and worms like Clonorchis sinensis and Opis torquis viverni. So how to remember? You can see C, 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 and that is 6C. What are the other risk factors? Hepatitis B virus, HIV, and hepatitis C virus. So how to remember? BHC. Asbestos, nitrosamines, dioxin. So this is and here diabetes mellitus, obesity, OCPs, smoking, thorotrust, isoniazid. So this is DOST. So how to remember? 6C, BHC, and DOST. These are the risk factors for cholangiocarcinoma. What is the most common site of cholangiocarcinoma? And the most common site of cholangiocarcinoma, it's hilum. And hilar cholangiocarcinoma, it's known as Klatskin tumor. Hilar cholangiocarcinoma, that is known as Klatskin tumor. You know that there are many similarities between cholangiocarcinoma and carcinoma gallbladder. What are the similarities? Both of these are adenocarcinoma. Non-specific tumor marker is CEA, specific tumor marker is CA99, and the chemotherapy regimen is same, gemcitabine plus cisplatin, and the histological types are same. So what are the similarities? Both of these are adenocarcinoma. Non-specific tumor marker, that is CEA, specific tumor marker, that is CA99, chemotherapy regimen, that is gemcitabine plus cisplatin, and histological types are same. So these are similarities between cholangiocarcinoma and carcinoma gallbladder. If the malignancy is here in the bile duct, so there is obstruction, and that's why what is the symptom? There is jaundice followed by weight loss. What kind of jaundice? There is painless progressive jaundice. So the most common symptom, it's the painless progressive jaundice followed by weight loss. Whenever there is obstructive jaundice, there are certain symptoms which are complementary, like anorexia, fatigue, patient is having itching, that's pruritus, and passage of clay colored stools. In majority of cases, the obstruction is here in the hilum. That's why gallbladder is non-palpable. In which cases gallbladder is palpable? Whenever the malignancy is located distally. So this is which law? This is Courvoisier's law. What is Courvoisier's law? In a case of obstructive jaundice, gallbladder is seldom palpable due to stone disease. It means because of stone there is chronic inflammation leading to fibrosis. So gallbladder is seldom means rarely palpable. What is the exact meaning? That in case of obstructive jaundice, gallbladder is palpable because of periampullary carcinoma. So the meaning is, in case of obstructive jaundice, gallbladder is seldom is rarely palpable due to stone disease. In case of obstructive jaundice, gallbladder is palpable due to periampullary carcinoma. So what are the exceptions of Courvoisier's law? Means there is stone in the gallbladder, or stones are there, but gallbladder is still palpable. So see the exceptions. Double impaction of stone means one stone is in the gallbladder and one in CVD. There is oriental cholangiohepatitis, that is also known as hepatolithiasis. If there is mucocele, gallbladder is already distended because a stone is impacted at cystic duct CVD junction. And whenever there is stone impacted at ampulla of Vater, there is jaundice, and proximal part of bile duct and gallbladder is dilated or distended. So these are the exceptions of Courvoisier's law. There is another question which is asked frequently. What is ampullary carcinoma and what is periampullary carcinoma? Ampullary carcinoma is arising directly from ampulla, and the periampullary carcinoma is arising within 2 cm of ampulla. So what are the malignancies which are included in periampullary carcinoma? So here you can see from ampulla malignancy is arising. This is ampullary, and if malignancy is arising within 2 cm of ampulla, that is periampullary. There are 4 malignancies which are included. First is ampullary carcinoma, second is carcinoma head of pancreas, third is distal cholangio, and the fourth is duodenal carcinoma. Out of these, which one is having best prognosis? Is the duodenal carcinoma, because it's a type of intestinal malignancy. This is having best prognosis. Which one is having worst prognosis? It's carcinoma head of pancreas. Carcinoma head of pancreas, this is having worst prognosis. So question, in which type of cholangiocarcinoma gallbladder is palpable? So obviously distal cholangiocarcinoma gallbladder is palpable. Okay, now see cholangio. So what is the investigation of choice for diagnosis of cholangiocarcinoma? Investigation of choice for diagnosis, and that is MRI plus MRCP. This is MRI plus MRCP. So what is the treatment? If there is involvement of hilum, means patient is having hilar cholangio, so we go for CBD resection plus lymphadenectomy plus routine caudate lobectomy. And if there is involvement of distal cholangio, here we go for pylorus preserving pancreaticoduodenectomy or pylorus preserving Whipple's procedure. So for hilar cholangiocarcinoma, we go for CBD resection plus lymphadenectomy plus routine caudate lobectomy, and for distal cholangiocarcinoma, it's pylorus preserving Whipple's procedure. See what is hemobilia? Hemo means blood, going into bile duct, hemobilia. What is the most common cause of hemobilia? It is iatrogenic, means during some investigation or intervention. Which intervention? Whenever we are going to perform PTC, percutaneous transhepatic cholangiography, there is injury of some minor vessel leading to bleeding into the bile duct. So this is hemobilia. Most common cause is iatrogenic, that is PTC. It is characterized by Quink's triad. What are the components? There is GI bleeding. What kind of GI bleeding? It can be upper GI bleeding or it can be lower GI bleeding. If there is upper GI bleeding, the patients are having hematemesis. There is lower GI bleeding, the patient is having melena. So there is hematemesis, or the patient can develop melena. Clear? So the components of Quink's triad are GI bleeding, clot colic, jaundice. Out of these, which one is most common symptom? The most common symptom of hemobilia, that is melena. And how much minimum bleeding is required for melena? That is 40 to 60 ml. Since there is bleeding, so what is the first investigation done? Endoscopy. But since there is bleeding, which investigation is both diagnostic and therapeutic? That is angiography. So first investigation done, that is endoscopy. And which investigation is both diagnostic and therapeutic? So angiography, it is both diagnostic and therapeutic. Good thing that hemobilia, the bleeding is minor, it stops spontaneously. So in majority of cases, what is sufficient? Conservative management. Imagine if patient is not improving after conservative management, we can go for angiography plus embolization. If it is not available or failed, then we can go for what? Open surgical ligation. So in majority of cases, what is sufficient? Conservative management. If patient is not improving, we go for angiography plus embolization. If it is not available or failed, we go for open surgical ligation. So this is all about bile duct. Now we are going to discuss pancreas. First of all, we are going to discuss pancreas division. In normal pancreas, you can see this is the accessory duct of Santorini and this is the main duct of Wirsung. Both of these are going to join together and there is one opening in the second part of duodenum, that is known as ampulla of Vater. What happens in pancreas division? There is divided drainage. So here you can see the body as well as the tail of pancreas. It is drained by accessory duct or dorsal duct of Santorini. And here you can see the head and uncinate process. It is drained by ventral duct of Wirsung. So there is divided drainage. Major part of pancreas is being drained by a minor duct, whereas little part of pancreas is being drained by the major duct. Because of this, there is relative outflow obstruction, and because of this relative outflow obstruction, these patients have recurrent attacks of acute pancreatitis. So in pancreas division, there is divided drainage. There is relative outflow obstruction, and because of that, the patients are having recurrent attacks of acute pancreatitis. What is the investigation of choice for diagnosis? Investigation of choice for diagnosis, that is MRCP. And what is the gold standard investigation? The gold standard investigation is ERCP. Why? Because we can perform the sphincterotomy with ERCP. What are the treatment options? Here you can see this is the dorsal duct. So in the dorsal duct you can perform dorsal duct sphincterotomy or dorsal duct sphincteroplasty. So treatment, in the treatment we can go for dorsal duct sphincterotomy or dorsal duct sphincteroplasty. This is sphincterotomy or dorsal duct sphincteroplasty. So this is dorsal duct sphincteroplasty. That is pancreas divisum. There is another abnormality of pancreas known as annular pancreas. In this annular pancreas you can see there is ring of ventral pancreas around the second part of duodenum. And because of this ring of ventral pancreas around second part of duodenum, there is obstruction. The good thing is that this obstruction is proximal to ampulla. So in this case, the obstruction is proximal to ampulla. Clear? And since the obstruction is proximal to ampulla, and that's why what kind of vomiting? There is non-bilious vomiting. In this patient, there is non-bilious vomiting. It is associated with two conditions. One is Down syndrome and the second is duodenal atresia. It is associated with Down's syndrome and duodenal atresia. Duodenal atresia. In duodenal atresia, the obstruction is distal to ampulla of Vater. And if obstruction is distal to ampulla of Vater, so what kind of vomiting is seen in duodenal atresia? There is bilious vomiting. In duodenal atresia, there is bilious vomiting. What is the investigation of choice for diagnosis of annular pancreas here? The investigation of choice for diagnosis, that is ERCP. ERCP is investigation of choice for diagnosis. And what is the treatment of choice for both annular pancreas as well as duodenal atresia? That is duodenostomy. So for both annular pancreas as well as duodenal atresia, the treatment of choice is duodenostomy. And for superior mesenteric artery syndrome, treatment of choice is duodenojejunostomy. So for superior mesenteric artery syndrome, it is duodenojejunostomy. So these are one-liner questions asked frequently. For duodenal atresia and annular pancreas, it is duodenostomy. For superior mesenteric artery syndrome, it is duodenojejunostomy. What is the most common cause of acute pancreatitis? It is gallstones followed by alcohol. There are no permanent changes in the pancreas because of gallstones, and that's why gallstone-induced pancreatitis, it's having best prognosis. So most common cause, this is gallstones followed by alcohol. An important point, these gallstone-induced pancreatitis is having best prognosis. Why? Because there are no permanent changes in the pancreas. What are the other causes of acute pancreatitis? It is caused by blunt trauma, especially in children, by ERCP, hypertriglyceridemia, hyperparathyroidism, and hyperparathyroidism leads to hypercalcemia. In both of these conditions, there is increased risk of stone formation. In carcinoma pancreas and cystic fibrosis also, there is obstruction in the pancreatic duct which can cause the acute pancreatitis. There are certain viral infections which can cause acute pancreatitis. So what are the viral infections? Mnemonic is CME. C means cytomegalovirus, Coxsackie virus, M means mumps, and E means ecovirus. Apart from these causes, there are certain drugs also which can cause acute pancreatitis. So best prognosis gallstone-induced pancreatitis, it's having best prognosis. What is the most common cause of death in acute pancreatitis within 2 weeks of hospitalization? So if it occurs within 2 weeks of hospitalization, this is because of multi-organ dysfunction syndrome. Multi-organ dysfunction syndrome. And what is the most common cause of death after 2 weeks of hospitalization? This is sepsis. Sepsis. What is the initial sign of MODS? There is impaired lung function, and it is because of ARDS. Impaired lung function because of ARDS. So death within 2 weeks of hospitalization, multi-organ dysfunction syndrome. Death after 2 weeks of hospitalization, sepsis. What are the clinical features? There is epigastric pain radiating to left side of back, which is partially relieved by sitting or bending forward. Apart from that, there is paralytic ileus, and because of this paralytic ileus, patients are having nausea and vomiting. Nausea and vomiting. Because of paralytic ileus, there are characteristic X-ray signs of paralytic ileus seen in acute pancreatitis. Because of paralytic ileus, the patients are having gasless abdomen on X-ray. There is ground glass appearance. There is sentinel loop because of localized ileus in jejunum. There is colon cutoff sign because of localized ileus in transverse colon, and there is renal halo sign. In these images, you can see there is localized ileus in the jejunum here, so that is sentinel loop, and here you can see the colon is visible till splenic flexure of colon. So this is what colon cutoff sign. Here you can see the arrow. So this is colon cutoff sign. This is sentinel loop. After that, in some patients of acute pancreatitis, there is retroperitoneal bleeding or hemorrhage, and there is bleeding along facial planes leading to ecchymosis. So whenever there is ecchymosis around umbilicus, this is known as Cullen sign. Whenever there is ecchymosis around flank, this is known as Gray Turner sign. And whenever there is ecchymosis around inguinal region, that is known as Fox sign. These are very, very important. Ecchymosis around umbilicus, Cullen sign. Ecchymosis around flank, Gray Turner sign. And ecchymosis around inguinal region, that is known as Fox sign. What is the investigation of choice for diagnosis of acute pancreatitis? And that is CCT. It is CCT. What is the best time to perform CT? After 72 hours of attack. After 72 hours. Why? Because CT is mainly done for detection of complications. Generally, how we make the diagnosis? We make the diagnosis on the basis of clinical features plus laboratory investigations. And you know which investigations are done. We go for amylase and lipase. You know, lipase is more specific than amylase. So generally, diagnosis is made by clinical features plus laboratory investigations. For detection of complications, we perform CT, that also after 72 hours. So investigation of choice is CECT, but the diagnosis is made by clinical features plus laboratory investigations. Now coming to the treatment. What is the cornerstone treatment in acute pancreatitis? This is fluid resuscitation plus oxygen supplementation. And what is the fluid of choice? Ringer lactate. There is pain. For the pain, we are starting what? Analgesics. So what is the NSAID of choice? NSAID of choice, it is metamizole. That is metamizole. And what is the opiate of choice? Opiate, and this is buprenorphine. Opiate of choice, that is buprenorphine. Second, patient is having paralytic ileus, that's why we have to start the nutrition. Which kind of nutrition is preferred? Enteral nutrition is preferred over total parenteral nutrition. So in acute pancreatitis, enteral nutrition, this is preferred over total parenteral nutrition. But in which cases we go for TPN, total parenteral nutrition? This is given in the patients of shock or the patients who are having severe acute pancreatitis. So in shock and severe acute pancreatitis, we give total parenteral nutrition. Antibiotics are routinely not given until and unless there are evidences of infection. So if patient is fever, then only we will start antibiotics. Otherwise, routinely antibiotics are not given. What are the prognostic scoring systems in acute pancreatitis? So there is Ranson score, modified Glasgow score, and Bishop score. In all these three, if the score is more than equal to 3, it means patient is having severe acute pancreatitis. Score more than equal to 3, there is severe acute pancreatitis. There is another scoring system, that is QSOFA, quick sequential organ failure assessment. There is Apache 2, that is acute physiology and chronic health evaluation 2. And what should be the score here? If it is more than equal to 8. There is CT severity index. It is equal to Balthazar CT grading, Balthazar CT grading plus necrosis score, and there is C-reactive protein. The value should be more than 130 milligram per ml. More than 130 milligram per ml. So these are the various prognostic scoring systems. 3 questions which are frequently asked. One is Ranson score, second is Bishop, and third is QSOFA. So what is Ranson's prognostic criteria for non-gallstone induced pancreatitis? You have to remember, this is for non-gallstone induced pancreatitis, because for gallstone induced pancreatitis it's a bit different. This one is most commonly asked in exam. So there are 2 set of parameters which we are going to assess. One at the time of admission, and the second after 48 hours. So first important point, that how much minimum time is required for complete assessment? 48 hours. Now see what are the parameters. First, age more than 55 years. Second, WBC count, how much? More than 16,000 per microliter. RBS more than 200 milligram per deciliter. LDH more than 350 international units per liter, and AST, that is more than 250 units per liter. So these are the parameters which are assessed at the time of admission. After 48 hours, fall in hematocrit more than 10 points. Blood urea nitrogen elevation more than 5 milligram per deciliter. Serum calcium less than 8 milligram per deciliter. Base deficit, that should be more than 4 milli equivalent per liter. Arterial PO2 less than 60 mmHg. And how much should be the fluid sequestration? More than 6 liters. So here you can see how many total parameters are there. 5 and here 6. So total 11. Out of these 11 parameters, if more than equal to 3 are positive, it means patient is having severe acute pancreatitis. There is only one problem, that how much minimum time is required for complete assessment? Yes, 48 hours. That's why if you need one scoring system for bedside assessment, we go for Bishop score. Bishop score means bedside index for severity of acute pancreatitis. So for Bishop, the mnemonic is also Bishop. B means blood urea nitrogen, how much? More than 25 milligram per deciliter. I means impaired mental status. S means systemic inflammatory response syndrome. How many parameters are there? There are 4 parameters. And how many should be present? More than equal to 2 of 4. Age more than 60 years, and there is pleural effusion. So total 5 parameters are there. In patients who are having severe acute pancreatitis, the score is generally more than equal to 3. So whenever it's more than equal to 3, patient is having severe acute pancreatitis. The third important is QSOFA, quick sequential organ failure assessment. So how to remember this QSOFA? The mnemonic is QRS-MS. This is QRS-MS. So here Q means QSOFA, R means respiratory rate, S means systolic blood pressure, and MS means mental status alteration. This is mental status alteration. This is the mnemonic QRS-MS. Now here the respiratory rate should be more than equal to 22 per minute. The systolic blood pressure should be less than equal to 100 mmHg, and the patient is having mental status alteration. All these parameters are having a score of 1. So components are respiratory rate, systolic blood pressure, and mental status alteration. So these are three important questions asked almost every year. According to revised Atlanta classification, what are the local complications of acute pancreatitis? So it is divided into two types, acute and chronic. If the duration is less than 4 weeks, in this particular duration, there is no defined wall. So this is acute complication, and after 4 weeks, there is defined wall. So that's chronic. First, in acute complication, we include acute pancreatic fluid collection. And the second is acute necrotic collection. There is acute necrotic collection. So acute pancreatic fluid collection, acute necrotic collection. After 4 weeks, this acute pancreatic fluid collection, which is present in lesser sac, it is walled off by granulation tissue. So it becomes pseudocyst. So after 4 weeks, it becomes pseudocyst, and the necrotic collection, it is walled off after 4 weeks. So this becomes walled off necrosis. It becomes walled off necrosis. These are the complications according to revised Atlanta classification. In this image, you can see that there is presence of this cyst in the pancreas. This is pancreatic pseudocyst. So why it is known as pseudocyst? Because it is a false cyst, because it is not lined by epithelium, it is lined by granulation tissue. So why pseudocyst? Because it is not lined by epithelium. Not lined by epithelium. What is the most common site of pseudocyst? Just behind the stomach, and that is lesser sac. So the most common site, this is the lesser sac. What is the most common cause of pancreatic pseudocyst? It is because of alcohol. So most common cause, that is alcohol. What is the good thing? In majority of cases, the size of cyst is small, and that's why patients are asymptomatic. But whenever it becomes large, see, it is in relation to the stomach. So that's why the patients are having abdominal pain, and the patients are having multiple episodes of what? Non-bilious vomiting containing undigested food particles. So clinical features, majority of patients are asymptomatic. But if cyst is large, what's the problem? There is abdominal pain. It can lead to abdominal pain, and there is vomiting. What kind of? Non-bilious containing undigested food particles. What are the complications? The most common complication is infection followed by hemorrhage. So the complication, most common complication, that is infection followed by hemorrhage. Right? And here you can see which investigation is this? This is CCT. So investigation of choice for diagnosis. Investigation of choice for diagnosis of pseudocyst, it is CCT. What are the treatment options? The most popular procedure, this is the cyst and this is the stomach. What we do, we create a communication between these two structures. So this is cystogastrostomy. This is the most popular procedure, but the treatment of choice is cystojejunostomy. So two options in the treatment, cystogastrostomy. This is the most popular procedure, but what is the treatment of choice? This is cystojejunostomy. The treatment of choice is cystojejunostomy. We discussed that most of the patients are having small pseudocyst. So generally, if the cyst is small, in majority of cases, spontaneous obliteration or resolution occurs. So most of the cysts resolve spontaneously. So what are the indications of surgery if the cyst is going to persist for more than 6 weeks or the size of cyst is 6 centimeter or more? So indications, we are not doing surgery in all the cases. So what are the indications of surgery? First, duration, you have to remember, duration more than 6 weeks, and what should be the size? Size more than equal to 6 centimeter. So in these cases, we go for the treatment, and the treatment of choice is cystojejunostomy. What happens in chronic pancreatitis? There is irreversible fibrosis of pancreatic parenchyma with ongoing inflammation, and because of this, there are three problems. First, there is exocrine insufficiency. Exocrine insufficiency. There is endocrine insufficiency, and there is chronic pain. There is chronic pain. Clear? You know that exocrine insufficiency precedes endocrine insufficiency. So because of exocrine insufficiency, patient is having indigestion, malabsorption, steatorrhea. Because of endocrine insufficiency, patient is having what? Diabetes mellitus. And these are the manifestations which are seen when more than 90% of acini and islet cells are permanently destroyed. What is the most common cause of chronic pancreatitis? It is alcohol. Heavy alcohol consumption. Heavy alcohol consumption. And you know, there are certain environmental factors like smoking, and smoking is having synergistic effect with alcohol, so it increases the risk of chronic pancreatitis. Since there is chronic pain, there is exocrine insufficiency, endocrine insufficiency. What is the most common symptom? The most common symptom of chronic pancreatitis? There is abdominal pain. What is the triad of chronic pancreatitis? The triad is diabetes mellitus, pancreatic calcification, and steatorrhea. So how to remember? Mnemonic is DPS. This is the triad of chronic pancreatitis. Diabetes mellitus, pancreatic calcification, and steatorrhea. In how many cases pancreatic calcification is seen? Generally, it is seen in 30 to 40% patients. So in this image, you can see what? There is evidence of calcification. In the pancreas, this is X-ray, and here you can see on CT, pancreatic calcification in chronic pancreatitis. What is the investigation of choice for diagnosis of chronic pancreatitis? Investigation of choice, that is MRCP. And what is the gold standard investigation, which can be diagnostic as well as therapeutic? So the gold standard investigation is ERCP. Why? Because it is diagnostic and therapeutic. What is the problem in chronic pancreatitis? So in this picture you can see this is the pancreatic duct, which is having what? Stricture, dilatation, stricture, dilatation, stricture, dilatation. These patients are having stones also. What is the composition of stone? Calcium carbonate. So this appearance is known as beaded appearance, string of pearls appearance, or chain of flakes appearance. Characteristic appearances. There is beaded appearance, string of pearls appearance, string of pearls, or chain of flakes appearance, chain of flakes appearance. Clear? Characteristic appearances in chronic pancreatitis we discussed. Investigation of choice for diagnosis, MRCP. Gold standard investigation, that is ERCP. Why? You can remove the stone. If there is stricture, you can insert the stent. So we discussed there are three problems. Exocrine insufficiency, that's why we give pancreatic enzyme supplements. Pancreatic enzyme supplements, what kind of? Enteric coated. For endocrine insufficiency, since the patient is having diabetes mellitus, what we give? Insulin. And for chronic pain, obviously we start analgesics. Analgesics. What kind of analgesics? NSAIDs like metamizole, which we gave in acute pancreatitis. Opiates like buprenorphine. Imagine, even after analgesics, if there is no improvement, in that case we go for ERCP plus stone removal or stenting. ERCP plus stone removal if it is responsible for obstruction, or if there is stricture, stenting. If still patient is symptomatic, there is no complete relief in the pain, then we block the ganglia. Which ganglia? Celiac ganglia block. We go for celiac ganglia block. Even after that, there is no improvement, then we go for surgery. And what are the surgical intervention? We have two types of procedures. One is drainage procedure and the second is resection procedure. In the drainage procedure, we perform Pusto procedure. What is this Pusto procedure? This is longitudinal pancreaticojejunostomy. How it's done? So in this image, you can see that I'm going to open the pancreatic duct and I'm going to perform the anastomosis of this pancreatic duct along its whole length with jejunum. So along the whole length, anastomosis is performed between pancreatic duct and jejunum. This is longitudinal pancreaticojejunostomy. In the resection procedure, there is Beger's procedure. Beger's procedure. And what is the other name of this Beger's procedure? This is also known as DPPHR. DPPHR. So what is the full form? Duodenal preserving pancreatic head resection. So in this image, you can see that I'm going to resect the pancreatic head and I'm going to preserve this duodenum. And this kind of anastomosis is done, pancreaticojejunostomy. So this is duodenal preserving pancreatic head resection, that is also known as Beger's procedure. The second resection procedure is Frey's procedure. This is Frey's procedure. And what is the other name of Frey's procedure? This is LRLPJ. LRLPJ means local resection of pancreatic head with longitudinal pancreaticojejunostomy. So in this image, you can see there is local resection of pancreatic head with longitudinal pancreaticojejunostomy. So this is Frey's procedure. Frey's procedure. So these are the procedures or surgical interventions which are done in patients of chronic pancreatitis. What is the most common cystic lesion of pancreas? And what is the most common cystic neoplasm of pancreas? If you're talking about cystic lesion, this is pancreatic pseudocyst. Most common cystic lesion, this is pancreatic pseudocyst in 75% cases. But if we are talking about most common cystic neoplasm of pancreas, this is mucinous cystic neoplasm. Another name is mucinous cyst adenoma. So in cystic neoplasm of pancreas, we include serous cyst adenoma, mucinous cyst adenoma, and intraductal papillary mucinous neoplasm. This is serous cystic neoplasm, which is also known as serous cyst adenoma. See, this is benign. It's a benign tumor. It is more common in females and generally it is asymptomatic. Generally, it is asymptomatic. Okay. What are the characteristic features? Serous cyst adenoma. So obviously, what kind of content? There is serous content in the cyst. The content is serous. Second problem, in these patients, there is decreased CEA. Why? Because it is benign and there is no pancreatitis. That's why there is decreased amylase. So if we see the cyst content, it is serous, there is decreased CEA and there is decreased amylase. Investigation of choice for most of the pancreatic tumors, it is CCT. So here also CCT. And what kind of appearance you can see here? This is central sunburst calcification. And what kind of scar is there? There is central stellate scar. So two important questions. Investigation of choice for diagnosis, that is CCT. And on CT, what kind of appearance? There is central stellate scar, central stellate scar, or there is central sunburst calcification. Central sunburst calcification. Clear? Patient is asymptomatic, tumor is benign. That's why in majority of cases, what is recommended? We go for observation. So in majority of cases, we go for observation. What is the most common site of serous cyst adenoma? You have to remember head. This is head. Second is mucinous cystic neoplasm, which is also known as mucinous cyst adenoma. Simple. We discussed that this is the most common cystic neoplasm of pancreas. See, it is pre-malignant condition. This is pre-malignant. Clear? And what is the most common site of mucinous cyst adenoma? This is body and tail. The most common site is body and tail. Okay. So content is mucinous is already written. The content is mucinous. It is pre-malignant condition. So what is raised? CEA. CEA. But there is no pancreatitis. Generally pancreatitis is not seen. So that's why there is decreased amylase. Clear? So the content is mucinous, there is increased CEA, and there is decreased amylase. These are the characteristic features. Most of the patients are symptomatic in mucinous cystic neoplasm. And what is the symptom? Yes, it is abdominal pain. Obviously, investigation of choice for diagnosis, that is CECT. And on CECT, there is peripheral eggshell calcification. Since it's pre-malignant, that's why what's the treatment? We go for surgical resection. The treatment is surgical resection in mucinous cystic neoplasm. Third is intraductal papillary mucinous neoplasm, right? This is also pre-malignant. It is pre-malignant and it is equally seen in males and females. Equally seen in males and females. Here, the most common site is head and uncinate process. So in IPMN, the most common site is head and uncinate process. Clear? The name is intraductal papillary mucinous neoplasm. So there is excessive mucin production. And because of this excessive mucin production, there is obstruction of the pancreatic duct. And that's why patients are having recurrent attacks of acute pancreatitis. So what is the manifestation? These patients have recurrent attacks of acute pancreatitis. And because of this acute pancreatitis, what is raised? Amylase. Amylase. So the content is mucinous. It is pre-malignant, so there is increased CEA and increased amylase. There is increased amylase, right? What is the characteristic appearance? Here you can see there is protrusion of mucin from the ampulla, and this is known as mucin protruding from fish mouth opening. On endoscopy, the characteristic appearance is on endoscopy, the characteristic appearance, it is mucin protruding from fish mouth opening. Fish mouth opening. Clear? On endoscopy. Since it's a pre-malignant condition, most of the patients are symptomatic. What is the treatment? We go for partial pancreatectomy. So partial pancreatectomy. This is management of IPMN. Important is the content, that is mucinous, there is raised CEA and there is raised amylase. What is the most common type of mutation in carcinoma pancreas and cholangiocarcinoma? The most common mutation, this is KRAS followed by P16. And what is the most common mutation in carcinoma gallbladder? This is P53 followed by KRAS. And the most common mutation in carcinoma stomach, that is P53 followed by COX2. P53 followed by COX2. So in carcinoma pancreas and cholangiocarcinoma, the most common mutation is KRAS, and in carcinoma gallbladder as well as in carcinoma stomach, in both, the most common mutation is P53. Now see, what are the risk factors for carcinoma pancreas? There are established risk factors and there are association. One of the established risk factor is smoking. That's the smoking, and hereditary factors. Hereditary factors. Clear? In hereditary factors, which condition is having maximum risk of malignancy? It is the Peutz-Jeghers syndrome. This was the latest question asked in exam. Peutz-Jeghers syndrome. So among hereditary factors, Peutz-Jeghers syndrome is having maximum risk. In associations, the mnemonic is DOC. D means diabetes mellitus, O means obesity, and C means chronic pancreatitis. Obesity and C means chronic pancreatitis. Clear? So these are the risk factors for carcinoma pancreas. Now we are going to discuss carcinoma pancreas in detail. What is the most common site of carcinoma pancreas? It is head followed by body followed by tail. So the most common site, this is head of pancreas followed by body followed by tail. Second, pancreas is a gland. So the most common malignancy, histological type, that is adenocarcinoma. And for adenocarcinoma, what is the non-specific tumor marker? CEA. For carcinoma pancreas, the specific tumor marker is CA99. What is the most common site of carcinoma pancreas? It is head, followed by body, followed by tail. You know, pancreas is a gland. So malignancy arising from gland, that is adenocarcinoma. So what is the most common type? This is adenocarcinoma. Clear? What is the non-specific tumor marker? This is CEA. You know, CEA is a non-specific tumor marker for adenocarcinomas. What is specific tumor marker? And that is CA99. What is the most common site of metastasis? Obviously, it is liver. And in chemotherapy, we give single agent. What is the name of that agent? We give gemcitabine. Gemcitabine. What is the most common symptom of carcinoma pancreas? Since the most common site is head, the most common symptom is jaundice followed by weight loss. If we see the types, patient is having ampullary carcinoma. Imagine if patient is having ampullary carcinoma. So in ampullary carcinoma, what is the most common symptom? There is jaundice. And in ampullary carcinoma, what kind of jaundice? There is waxing and waning of jaundice with melena every 2 to 3 months. And this is seen in 1/3 of the patients. Waxing and waning of jaundice with melena every 2 to 3 months. In carcinoma head of pancreas also, the most common symptom is what? Jaundice. That is jaundice. But if patient is having body or tail tumors, in body and tail tumors, the most common symptom is weight loss. It is weight loss. So overall, most common symptom is jaundice followed by weight loss. These are the 3 terms which are asked in exam. One is Trousseau syndrome. So what is Trousseau syndrome? It is migratory superficial thrombophlebitis seen in malignancy. This is migratory superficial thrombophlebitis. Migratory superficial thrombophlebitis seen in malignancy, and most commonly which malignancy? Carcinoma pancreas. What is Trousseau sign? This is carpopedal spasm in hypocalcemia. So Trousseau sign, this is carpopedal spasm. Carpopedal spasm in hypocalcemia. In hypocalcemia. Clear? And what about Troisier sign? This is the left supraclavicular lymphadenopathy in malignancy. This is left supraclavicular lymphadenopathy in malignancy. The name is Troisier sign. And what is the name of this lymph node? This is known as Virchow's node or signal node. So the name of this lymph node, that is Virchow's node, also known as signal node. What is the investigation of choice for diagnosis of carcinoma pancreas? That is CECT. We discussed that the most common site of carcinoma pancreas is head. So there are characteristic radiological signs which are seen in carcinoma head of pancreas. Have a look. In carcinoma head of pancreas, what are the radiological signs which are seen? Carcinoma head of pancreas, the radiological signs which are seen: widening of C-loop, there is antral pad sign, reverse 3 sign of Frostberg, and double duct sign. In this image, you can see that there is indentation by the tumor at the antrum. So what is the name of this sign? This is antral pad sign. Can you see here? Antral pad sign. In this image, you can see the medial wall of duodenum is marked because of inflammatory changes in carcinoma head of pancreas, and this is known as reverse 3 sign of Frostberg. Reverse 3 sign of Frostberg. In this ERCP, you can see the pancreatic duct and you can see the bile duct separately. Bile duct and pancreatic duct separately. So this is what? Double duct sign. So these are the image based questions which are frequently asked. In management of pancreatic tumors, we follow certain principles. See, any tumor which is located in body and tail, any kind of tumor, we go for distal pancreatectomy. So any tumor located in body and tail, we go for distal pancreatectomy. If there is benign tumor located in head, so for benign tumor located in head, we go for enucleation. That is enucleation. And if there is malignant tumor located in head. So for malignant tumor located in head, we go for pylorus preserving Whipple's procedure, which is also known as pylorus preserving pancreaticoduodenectomy. So for body and tail tumors, distal pancreatectomy. For benign tumors involving head of pancreas, enucleation. And for malignant tumors involving head of pancreas, pylorus preserving pancreaticoduodenectomy. So how we manage carcinoma pancreas? Have a look. In carcinoma pancreas, we can perform Whipple's procedure, that is also known as pancreaticoduodenectomy, or Longmire-Traverso procedure, which is also known as pylorus preserving Whipple's procedure, also known as pylorus preserving pancreaticoduodenectomy. So here you can see that I'm going to preserve the pylorus. So rest of the anastomosis is seen. What is the first anastomosis? There is pancreaticojejunostomy. There is second anastomosis, that is hepatico or choledochojejunostomy, and the third anastomosis in Whipple's procedure, gastrojejunostomy. What is the difference in Longmire-Traverso procedure and Whipple's? The first anastomosis is same, second anastomosis is same. Here you can see I am preserving pylorus, so third anastomosis is duodenojejunostomy. Simple. So in these anastomosis, maximum risk of leak occurs at which site? It is pancreaticojejunostomy or PJ. Why? Because there is secretion of digestive enzymes. So first important point, that out of Longmire-Traverso procedure and Whipple's, which one is preferred? Longmire-Traverso, which is also known as pylorus preserving Whipple's procedure, which is also known as pylorus preserving pancreaticoduodenectomy. What are the one-liner questions which are asked in relation to surgery? Maximum risk of leak after pancreaticoduodenectomy occurs from PJ, pancreaticojejunostomy, followed by GJ, gastrojejunostomy, followed by HJ, that is hepaticojejunostomy or choledochojejunostomy. Most common complication of pancreaticoduodenectomy, and that is delayed gastric emptying. This is delayed gastric emptying. Clear? What is the most common cause of death after pancreaticoduodenectomy? That is cardiopulmonary complications. Some patients are going to expire because of myocardial infarction. So this is cardiopulmonary complication. Most important predictor of survival, complete tumor resection. So that is R0 resection. That's R0 resection. And what is the most important margin in pancreaticoduodenectomy? That is uncinate margin. It is also known as retroperitoneal margin, also known as superior mesenteric vessel margin. So most important margin, it is uncinate margin or retroperitoneal margin or superior mesenteric vessel margin. Now we are going to discuss neuroendocrine tumors of pancreas. What is the most common neuroendocrine tumor of pancreas? This is non-functional or PPOMA. PPOMA means arising from PP cells, that is pancreatic polypeptidoma. What is the most common functional neuroendocrine tumor of pancreas? It is insulinoma. And you know, 90% of insulinomas are benign. So what is the most common functional and malignant neuroendocrine tumor of pancreas? And that is gastrinoma. This is gastrinoma. See, all neuroendocrine tumors of pancreas except insulinoma are going to express somatostatin receptor. So for all neuroendocrine tumors of pancreas, what is the investigation of choice for localization? Investigation of choice for localization, and it is SRS. Full form, somatostatin receptor scintigraphy. Only exception insulinoma, because insulinoma doesn't express somatostatin receptors. One by one we are going to discuss. First we are going to discuss insulinoma. Insulinoma is the most common functional neuroendocrine tumor of pancreas. What is the most common site? It is equally distributed in head, body and tail. Equally distributed in head, body and tail, and 90% of insulinomas are benign. It is characterized by a triad known as Whipple's triad. So what is the problem? Because of increased insulin release, patient is having hypoglycemia. So the components of Whipple's triad: symptoms of hypoglycemia, how much is the blood glucose level? 45 to 50 milligram per deciliter, and there is improvement in symptoms after taking oral glucose. Whipple's triad. Insulinoma is a painless condition, and since patient becomes symptomatic because of hypoglycemia, patient has frequent habit of eating. So this is painless, and because of frequent eating, there is what? Weight gain. So it's a painless condition and there is weight gain. What is the gold standard investigation for diagnosis of insulinoma? It is 72 hours fasting. So the gold standard investigation is 72 hours fasting. This is 72 hours fasting. And we assess the insulin to glucose ratio. How much should be the insulin to glucose ratio? Insulin to glucose ratio should be 0.4. Whenever it is more than 0.4, we stop the test because condition is diagnostic. How we are going to localize? Because insulinoma is not going to express somatostatin receptor. So, investigation of choice for localization. This is intraoperative endoscopic ultrasound with manual palpation. This is intraoperative endoscopic ultrasound with manual palpation. This is the investigation of choice or best investigation for localization. Insulinomas are benign. First, we have to control the hypoglycemia. So, in the management, which drug we give? Digoxide. Digoxide is given to control the hypoglycemia. For body and tail tumors, we perform distal pancreatectomy. So, distal pancreatectomy, it is performed for body and tail tumors. And if the tumor is located in head, since it is benign, so for head, we go for enucleation. So if the tumor is located in head, we go for enucleation. Gastrinoma is also known as Zollinger-Ellison syndrome. So what is the problem? There is increased secretion of gastrin. Because of that, there is increased secretion of acid, and because of this increased secretion of acid, patient is having peptic ulcer disease. What is the most common site of gastrinoma? It is duodenum. So the most common site of gastrinoma, that is duodenum followed by pancreas. It is duodenum followed by pancreas, and in duodenum, what is the most common site? This is first part followed by second part followed by third part. It is not seen in fourth part. So the most common site is duodenum. It is sporadic in 75% cases, but in 25% cases, it is associated with MEN1. This is the latest question. So what is the most common site in MEN1? In MEN1 also, the most common site is duodenum. You know, gastrinoma is located in a triangle, that is gastrinoma triangle. So 90% of gastrinomas are located in this triangle. This is gastrinoma triangle, also known as triangle of Passaro. Gastrinoma triangle, also known as triangle of Passaro. What are the boundaries? This is cystic duct CBD junction. This is body and neck of pancreas, and this is second and third part of duodenum. Cystic duct CBD junction, body and neck of pancreas, and second and third part of duodenum. Clinical features. So patients are having multiple ulcers, recurrent ulcers, refractory ulcers, jejunal ulcers. Because of these ulcers, what is the most common symptom? It is abdominal pain. Abdominal pain. Apart from abdominal pain, the patients are having retrosternal heartburn. There is dyspepsia, symptoms of reflux, and there is diarrhea. Acid-induced diarrhea. What kind of diarrhea? Acid-induced diarrhea, and nasogastric aspiration characteristically halts this acid-induced diarrhea. How to make the diagnosis? So here, there is increased gastrin. Which value is diagnostic? More than 1000 picogram per ml, or we can go for basal acid output. So there is increased basal acid output. What's the value? More than 15 milliequivalent per hour. What is the best provocative test for diagnosis of gastrinoma? And that is secretin stimulation test. Secretin stimulation test. This is the best provocative test for gastrinoma. What is the investigation of choice for localization? So it is SRS, investigation of choice for localization, that is SRS. Clear? For the management, we have to give the drugs. So what is the drug of choice? Obviously, drug of choice is PPI because there is increased acid production. What is the treatment? If the tumor is located in body and tail, we go for distal pancreatectomy. And if the tumor is located in head, we go for pylorus preserving pancreaticoduodenectomy. This is glucagonoma. In glucagonoma, there is diabetes mellitus or hyperglycemia, and there is dermatitis. So this is also known as hyperglycemic cutaneous syndrome. It is also known as 4D syndrome. So what are the components of 4D? So 4D means diabetes mellitus, D means dermatitis, D means DVT, and D means depression. 4D syndrome. Out of these 4D, what is the most common symptom? It is necrolytic. This is necrolytic erythema migrans. This is the most common symptom. Clear? So this is dermatitis. Here you can see this is necrolytic erythema migrans, most common symptom. In glucagonoma, there is increased glucagon. So how we are going to make the diagnosis? There is raised glucagon. What is the investigation of choice for localization? It is SRS, somatostatin receptor scintigraphy. What is the most common site? It is body and tail. Most common site of tumor is body and tail. And if the tumor is located in body and tail, what is the treatment of choice? And that is distal pancreatectomy. Distal pancreatectomy in glucagonoma. VIPoma is also known as Werner-Morrison syndrome, also known as pancreatic cholera, also known as WDHA syndrome. What is the full form? WD means there is watery diarrhea. H means there is hypokalemia. And A means achlorhydria. There is achlorhydria. So what happens? Patient is going to pass 4 to 6 liters of liquid stool like cholera, and the tumor is located in pancreatic tail. So it is pancreatic cholera. Because of this watery diarrhea, there is loss of what? Loss of sodium. There is loss of chloride, loss of potassium, loss of bicarbonate. So these are the electrolytes which are decreased. Clear? What is increased? You have to remember there is increased calcium and increased RBS. This is asked in exam. So in VIPoma, there is hypercalcemia and hyperglycemia. It's a medical emergency because of hypovolemia and dyselectrolytemia. So when patient comes, what's the treatment? We give IV fluids plus correction of dyselectrolytemia correction. When patient is resuscitated, we have to perform the investigation. In this case, there is increased VIP levels. Investigation of choice for diagnosis is SRS. Most common site of tumor is tail. And if the tail is the site, most common site of tumor is tail. So what is the treatment of choice? This is distal pancreatectomy. Clear? So this is how we manage the patients of VIPoma, and this completes the pancreas.